Well, welcome friends and colleagues. We're just going to give it a couple seconds for folks to join, and then I'm going to do a brief overview of some logistics items before I pass it off to CDA Director Susan DeMorris.
Hey, Maria, you want me to jump in now?
Oh, if you want to jump in.
You're going to do some logistics for us.
I am. Yeah,
okay.
I was watching the attendee numbers climb and
okay, gotcha.
So just a couple of reminders. We're doing this meeting virtually, so you can join us on your smart device or your computer. And of course, there's always an option to dial in on your telephone using the telephone number and meeting ID displayed. Live captioning is available. If you select the transcript or CC icon on your Zoom toolbar, you'll be able to see the subtitles. We also have American Sign Language, and our friend Kim is here signing, and her colleague is on as well. They'll be kind of alternating throughout today's program. And as always, the recording slides and transcripts are archived on the California Health and Human Services Community Living webpage. So if you're looking for slides or former recordings, you can go there to find them. And with that, Susan, I think this is your moment.
All right. Thank you so much, Maria, and welcome back, everybody. It's good to see you, and I'll be seeing more of you when I start scrolling through the gallery. We last met on November 16th. That feels like a lifetime ago, and there's so much good news to share since then. I wanted to start out by first especially welcoming two new members to DACLAC. Megan Burke, who represents the SCAN Foundation, and Jeannie Parker Martin, representing Leading Age California. Megan and Jeannie have been key leaders on a wide range of aging and disability issues, including development of the Master Plan for Aging, and we're fortunate to have their expertise now joining us at this table. Welcome, Megan and Jeannie. I wanted to start with, there's a round of good news, and I'll go in chronological order. The first was on December 29th, the Centers for Medicare and Medicaid Services, that's CMS, approved California's far-reaching Medi-Cal CalAIM proposal. I want to give kudos and congratulations to California's tough negotiating team, led by our DHCS Director, Michelle Boss, and California's Medicaid Director, JC Cooper, who you'll hear from shortly. CalAIM officially launched on January 1st. Just a couple days later, on January 4th, CMS officially approved California's $3 billion home and community-based services spending plan. You'll hear that referred to as the Hcbs spending plan, and that was authorized by the legislature and the governor. You'll hear more about that today. On January 10th, Governor Newsom released his proposed 2022-2023 state budget. A fact sheet was attached to your agenda, and I hope by now most of you are familiar with some of the exciting proposals and initiatives laid out in the budget, but highlights include a major expansion of Medi-Cal, $1.7 billion in workforce investments, and that's on top of nearly $1 billion in workforce investments this year through that Hcbs spending plan I mentioned, funding to make permanent IHSS backup providers, and decreased Medi-Cal premiums for working disabled adults. There's quite a bit more in the budget, and you'll be hearing more about that in the coming months. Then, that only got us to January 10th. Later in January, together, we celebrated the 1-year anniversary of the Master Plan for Aging. I know many of you from who are on today's call were part of that celebration event, and several of you presented. We started the day with a video from Governor Newsom, and we were joined by the Secretaries of Health and Human Services, Housing, Labor, and hundreds of stakeholders. So thank you all who participated in the celebration event, and we'll make sure you see the 1-year progress report in the chat today. Later in January, we launched the California Elder and Disability Justice Coordinating Council. This has been many years in the making and was one of the recommendations in the Master Plan for Aging. I know that some of the members of the Coordinating Council are also on DACLAC and are participating today as public members and stakeholders. Also in January, the Department of Aging was proud to welcome Sarah Steenhausen to our team as the Deputy Director of Aging Policy, Research, and Equity. You'll be seeing Sarah later on the agenda when she facilitates our CalAIM discussion, along with Patty, our co-chair. And last, we continue to fight the COVID pandemic and the Omicron surge on all fronts: vaccines, boosters, testing, masks. And just this week, with the surge receding, we saw some welcome relief from the Department of Public Health, some relaxation on visitation policies in nursing homes, RCFEs, and other signs of progress against the variant. Before I turn over to Claire Ramsey, who's going to give us an update from the Department of Social Services on some of those Hcbs spending plan initiatives, I wanted to especially thank the transportation and housing work groups. I so appreciate the work that is happening between meetings and the leadership that members of this committee are showing to pull together not just members of DACLAC, but other subject matter experts and resources that you're tapping into. And I very much look forward to hearing from the transportation work group later today. I know the housing work group continues to meet. I want to thank Megan from Leading Age for her part, Marty, Patty, and others who've been doing work between meetings. And I urge you to do more of this. When we only meet quarterly for a short period of time, we can make more progress and bring recommendations forward to the group and ultimately to Secretary Galley by meeting in between meetings. And you have the support of our staff and team to help you get organized around those meetings in any way that you need. So now I'd like to turn it over to Claire Ramsey if she's joined us, and ask her to highlight two key initiatives that are now underway for IHSS workers and in the housing space. Claire.
Yeah, thanks, Susan, so much. And really excited to be here with all of you today in the new year with all these new initiatives going. So I am going to touch on two different initiatives, but I'm going to sneak in a third. I hope Susan doesn't mind. I just want to make sure everyone knows that in our IHSS realm, we had two major initiatives in the Hcbs spending plan. The first was our IHSS care economy payments, and we were actually able to send those out right at the end of January, beginning of February. That was a $500 stipend to every IHSS provider that worked between March 2020 and March 2021 for at least 2 months. That resulted in more than 550,000 IHSS providers receiving that additional stipend to basically recognize the extraordinary work they did during the pandemic. We are still extremely thankful for all that work and how many people they kept safe, and glad that we were able to show that appreciation by recognizing it with some actual dollars. So that was my extra, my third, but let me go to the other two. So the ongoing one we're working on very heavily in IHSS is our IHSS career pathways. Some of you may be pretty familiar with this because we have had two listening sessions, one in December and one in January, and we are planning a third for end of this month, beginning of March. We're still settling a date with particular focus on language access to make sure we have translation services beyond ASL in the listening session, so that we can hear from even more consumers and providers to make sure that we are using stakeholder feedback to inform our program. For those of you who aren't that familiar with our career pathways, I'm going to go through a little bit, but I'm not gonna, there's more to know. So let me know in the chat if you need any follow-up questions or want any follow-up information. Basically, what we are doing is starting a career pathways to really recruit and retain IHSS providers. And we are also doing it with an eye toward working cross-departmentally and cross-agency because there are a lot of career and workforce initiatives going on. And so we want to be thoughtful about the fact that people could be using our trainings as they currently work as an IHSS provider, but may also at some point in their career choose to make other choices in the healthcare field or social work field. And we're hoping to find a nice balance of having connectivity between programs. And so we're going to have two general pathways available. One is going to be a general health and safety pathway that'll focus on, a wide variety of topics like first aid, infection control, emergency and disaster preparedness, food safety. And then the second general pathway will be an adult education pathway, English for language learners, computer and digital literacy, math and financial literacy. These are sort of examples. We're going to be contracting with vendors to provide the classes. We also have 3 specialized pathways that are really super focused on our IHSS consumer population and needs we see there. The first is on cognitive impairments and behavioral health. So we're hoping to find having classes around dementia and Alzheimer's, developmental disabilities and autism spectrum disorders, and traumatic brain injuries. The second is our complex physical care needs. Might have classes around things like mobility, ambulation and transfer, amputation and prosthetic care, using a Hoyer lift and moving people safely. And then third will be a transition to home and community-based living from out-of-home care or homelessness. So those might be things like how to do care management for people, thinking about how to navigate the health system, support for reentry from homelessness, and whether that links into also some behavioral health needs. So we're really excited. We're working to actually do many pieces at once right now, but we will be hopefully launching at the very end of September, beginning of October of this year with our classes. They will be a lot of online options, but we are looking at in-person options as well. We do plan to have multiple languages represented. And we're really trying to focus on the content that IHSS and also waiver personal care services, WPCS providers need to provide high quality services and to feel comfortable with the services they're providing. We are also going to be able to pay people for their hourly wages to participate in the trainings. And then we do have an incentive program set up that we're setting up to pay people for both completing certain numbers of hours of classes and also completing hours and working for a new consumer to hopefully expand the pool of who's working. And I just want to say that we are still building this. So if you have feedback, we have heard a lot from stakeholders, like I said, through the listening sessions, but also through emails and our mailbox. So feel free to continue to provide us with that. It is helping inform the classes. We are very cognizant that this is a self-directed program and that individual recipients are going to direct their provider. So the training is really meant to provide a foundational base of skills and competencies with the understanding that consumers will be the employer and will be directing their actual services as they're applied to themselves. So more in the future, we'll be sending out that next listening session as soon as we have that date locked down, but excited about that moving forward. And then the other program I want to highlight that was within the Hcbs spending plan is our Community Care Expansion or CCE program. And this is a new program which will fund the acquisition, construction, and rehabilitation of adult and senior care facilities that serve applicants and recipients of SSI or our CAPI program, which is Cash Assistance Program for Immigrants, who are at risk of homelessness or experiencing homelessness. So DSS is actually working very collaboratively with the Department of Healthcare Services because they have a huge initiative going as well called the Behavioral Health Continuum Infrastructure Program, or BSIP. And the two programs are doing different things, but they are doing very complementary things. And so we released a joint RFA on January 31st. And with that, the CCE program is launching $570 million of funding available for expansion of these residential care facilities. And the BSIP program is releasing $518 million within this round of their funding. We are doing rolling applications at DSS for this program, and DHCS is doing a deadline of May 31st, 2022. So just want to flag those differences. We will have additional information coming out about the additional $195 million we have within CCE that will be used toward preservation of existing facilities. And we expect to have that, that guidance out by the end of this month, beginning of March. So we're super excited. I'm going to put in the chat our link to our RFA and to additional information about CCE, but obviously much more to come. And, you know, we're really seeing this as an amazing solution to make sure that SSI recipients have safe and stable housing when they also have a care need that needs congregate care, and also thinking about how it can connect in toward deinstitutionalization and helping people move out of SNFs and other institutional settings when a congregate setting might be more appropriate. So I think there's just going to be an amazing amount of good work to be done here, and really excited to continue to work with all of you together. I'll turn it back to you, Susan. Thanks for giving me the time today.
Thank you, Claire. Those were very timely announcements, and we're so happy to hear the good news that things are already underway. So at this point, I want to turn it over to our exceptional co-chairs, Eric Harris and Patty Prunhuber, who will lead us. We're in capable hands, and I want to especially thank all of the department directors and agency representatives who are with us today on the call. Thank you for joining us. We're so happy that you're here, and to public members and participants joining us, and especially to the members of this committee. So I will turn it now to our co-chairs.
Thank you, Susan. And Eric and I want to welcome everyone on the call. It's very exciting to see the level of participation. I see we have 111 people who are tuning in today to both hear from the different departments about their initiatives to advance community living and the Olmsted principles, and what the administration is bringing to that is very exciting. And then we're also going to have a lot of opportunity to hear from our stakeholders, our reactor panels, and the public, so that they can be the primary focus of this committee to really advise the administration on what the needs are. And without saying more, I'm going to turn it over to Eric so he can make a few comments as well.
Thank you so much, Patty. This is Eric Harris. I'm one of your co-chairs, and I'm also the Director of Public Policy at Disability Rights California. And I just want to echo the comments that, that Patty just mentioned. We're really thrilled that so many people are participating and involved. That's been really important to us as co-chairs, and I know it's really important to Susan as well. We really want to lift up the voices of the disability and aging community and make sure that policies that we are talking about, the departments that we are working with, that they hear directly from the disability and aging community, and that they prioritize listening directly to the disability and aging community. So I'm really excited about the topics that we're going to cover today: housing, CalAIM, transportation. I know that those work groups have all been gathering together or plan on gathering together very soon. And so we're really excited to hear what you all have to say and to hear from the different directors and different department heads to let us know what they're working on and what their thoughts are moving forward as well.
Should we go right into housing, or was there going to be some more introductions? Okay, thank you. I needed that slide, Maria.
And I know that we've done introductions with this group, and you all know that sometimes introductions can take some time. So if we could try to keep the introductions as efficient as possible so that we can get to the presentations, that would be really helpful.
Thanks,
And I'll
Eric.
just add, if anybody wants to put it in the chat, because that's a more accessible format for them, we would of course be happy to read from the chat any introductions that are there. Somebody want to start us off?
Thank you, Patty and Eric. I just want to jump in, and I think because we have such a tight agenda today, we're going to skip doing the roll call. The names are there on your screen. I hope that folks who are joining as attendees can also see the committee members who are in as panelists, so feel free to scroll through there. For committee members, feel free to use the chat to say hello to your fellow members, and we'll move right along into our next segment.
Thank you. And I see people are putting their introductions and hellos into the chat, so that'll be a great way to connect.
And I already provided the committee updates. So we can just roll right into housing for all ages and stages.
Excellent, thank you. So I assume you recall at the last meeting, we had a very lively conversation about housing for all ages and stages, which is one of the master plan for aging goals. And we had presentations from our Secretary of Business, Consumer Services and Housing, our Deputy Secretary. And then we heard from Allie Kennington from the Kelsey Project and Sharon Rapport and others from Corporation for Supportive Housing about some initiatives that might address some of the housing issues that are of particular concern to low-income older adults and people with disabilities. Out of that, we decided that there should be a housing work group that would, as Susan mentioned previously, really be able to drill down on one or more proposals and make recommendations and have some very specific feedback to give to the administration on what is needed. And the housing work group, which if you are interested, I see some people have already expressed interest in the chat. That is a fine way to let us know. And I'm gonna, can you go back one slide? Because I'm gonna let somebody else do that one. It is that we wanted to really make sure that the housing work group was focused on the MPA goals related to housing, which are housing for all ages and stages, and then a particular focus on preventing and ending homelessness among older adults and people with disabilities. That's initiative number 117 in our many, many initiatives. And we know we have a lot of work to do, which is why this housing work group is so important. And that we also want to align it with our overall DACLAC purpose, which is to advance community living, inclusion, and integration, rooted in both the Olmstead decision and in our own state's values of inclusion, access, and equity. And I'll just mention, and in compliance with the Hcbs settings rule, which is a rule that says we must provide community-based settings for Medicaid to provide home and community-based services. So now I'm going to turn it over to Marty, who's going to talk about the next slide, Marty Emoto.
Sorry, I had to mute myself. Thanks, Marty Emoto, family member, CCAN, California Disability Senior Community Action Network. And by the way, Susan, you did a remarkable job yesterday on your first subcommittee hearing. So that's baptism in fire, right? So, and thank you, Patty and Eric. And, on this work group, and again, I think we all appreciate that this committee is really anxious to do really substantive work that is meaningful to people. Housing, as we talked about in the last meeting, is so foundational. There are some foundational person-centered, whole person aspects to the work that we do. Housing is one of them. Transportation is another. Food security is another, and so is health. Housing, though, is so foundational because everything that we do requires that a person lives in a home or in a setting like a home. And so I'm glad that we came together in the last meeting to really focus on this issue by creating a work group that's open to all committee members and also open to non-committee members who have an expertise in this issue. We decided initially when we talked last week, Patty and Megan and myself and Amanda, that we'll make a commitment to meet at least 8 times a year, starting in March, every month except for the months when this advisory committee is meeting. And that's just not for the sake of meeting. We're looking at moving forward on really achievable goals that are meaningful and linking back to the individual, where whatever we do will make a difference. It's person-centered and make a difference in that person's life. And there's specific recommendations and initiatives to advance the master plan for aging housing goals, as Patty was talking about, consistent with this committee's purpose. What I like about this is that I worked on the master plan on the 2 subcommittees, and Susan was, a huge leadership role there, along with so many others. Is what I liked about it is that we divided some of the goals up into what was immediately achievable, middle term goals, and longer term goals. And the reason for that is we have all worked as advocates where we worked on aspirational goals that are never achieved. And the communities that we represent and speak for are so desperate, and the issue of housing is so urgent that we had to look at achievable victories and things that we can do now. And what I liked about the master plan is it actually outlined very achievable goals that actually were cross-cutting, that crosses all the systems and actually impacted people with disabilities, older Californians, people with mental health needs, people who are deaf, across all systems. So I think this is really a good effort. And then we welcome anybody on this committee and also members of the public who have an expertise in housing to join us, and just put a word in the chat that if you're interested. And I think Amanda has the job of going through the chat and locating everyone. So thank you. Passing on to Megan. Megan, is Megan here?
Yeah, can you hear me?
There you are, Megan. Okay.
All right. Well, first of all, thank you so much to Susan and your team for really letting DECLAC roll with this. And thanks to Patty and Marty for your leadership. I think now we just kind of wanted to hear from the group to make sure that we're on the right track with this, and that we are, forming this subcommittee to look the way that you hope it will look and do the things that you hope it will do. So, yeah, for that, we'll just take some comments.
And I will add, we haven't had this discussion, but my sense is that at least initially the meetings will continue in a virtual fashion as we sort of figure out access and how we are doing. And so I see that there's a hand up. Megan, I'm going to let you handle the
Okay, Robert.
Yes. Good afternoon. Sorry for coming in so late. I had some things to do here in Clear Lake, but my name is Robert Mylan Taylor. I'm the consumer advocate of your California Health and Human Services Disability and Aging Community Living Advisory Committee. And I also sit as the Disabled Consumer Representative of the Lake County In-Home Supportive Services Public Authority Advisory Committee and a chairperson. And I'm a resident of the city of Clear Lake in Southern Lake County. And I'm glad they're bringing this issue up of housing, because housing is really, really important. I have just found out that there were a lot of people in my city of Clear Lake that had been relocated to Clear Lake Oaks. Most of them were people that have been homeless. And in a county like ours, where there's no place for homeless people to be, housing is something that's really important. So I put it in the chat box, and I'm interested in being part of this subcommittee. And let me know if there's going to be any emails out there of what we're going to be discussing and what we're definitely going to be forwarding to our committee regarding this issue. I had a chance in the previous Olmsted Advisory Committee to be part of their housing subcommittee, and we accomplished a lot. And I hope we can definitely accomplish a lot in the California Health and Human Services Disability and Aging Community Living Advisory regarding housing, because that's something that's really important, not only for myself as a self-advocate as well, but for others across the state.
Thank you, Robert. I love your enthusiasm, and yes, we too hope to accomplish a lot through this subcommittee.
Thank you so much.
All right. Well, seeing no other comments, I'll hand it back to you, Patty.
Thank you. I guess what I'll say is you'll be hearing from us. Marty is going to take the lead here, and we can talk about a co-facilitator. We want to keep these meetings effective. I won't say short, but certainly productive and goal-oriented. And I'm really excited by the level of participation that we're seeing. And if you change your mind after hearing all this and want to put your name in the chat, just we'll keep track of that as a way to know who would like to be part of it. I think we have about, I'm going to say about 12 people right now, which is a great size, but we are welcoming others as well. The most important thing is that we have a real broad range of voices so that we can really represent the range of community need and interests. So thank you all for your interest.
I just want to add quickly, Marty Emoto, just do a shout out to Michelle. We have mutual friends that have always been on the very edge of being homeless, people with disabilities, people with developmental disabilities. Actually, Michelle and I have a mutual friend, and I was going to follow up with you about her housing situation. I was facing eviction when we were fighting suspension of the Lanterman Act in 2003. And there's so many people in my family or others who, are right on the edge. And so I think the other thing that Patty underscored in our other meetings, and so did Megan and others, is the sense of urgency of this issue. It's not just something that we just want to do because we have nothing else to do or it's foundational. It is an urgent issue impacting all of us, many in our families, and it's, again, so foundational. So appreciate the co-chairs of this committee, Susan, Eric, and Patty, for really allowing this to happen in this way. Back in 2005, when Homestead first started and I was on it, and Sarah Steenhausen actually was staffing it, we tried to form subcommittees, but it took a while before we were focusing on the issue of housing. And I'm so happy that we're doing that now. So thanks, and sign up, because if you don't sign up, we're going to draft some of you.
Thank you, Marty. I think we're ready to move on.
You, Patty. I don't know, Susan, if you want to jump in here and introduce JC, or if we should just streamline and pass it right off to JC.
I am happy to welcome JC Cooper, California's Medicaid director, somebody who has just done a phenomenal job in recent years with all things Medi-Cal, and I can't thank JC enough for her tremendous work in negotiating our CalAIM proposal at the tail end of the year, and for the great success that she and her team achieved with that approval to enable all of us to start the year out. So welcome, JC. We're so glad you could spend time with us today, and we're really looking forward to hearing from you.
Great. So we can go ahead and progress to the first slide. Perfect. So the two main things I'm going to walk through for you all today is the home and community-based service spending plan components, as well as the various CalAIM components. So on both of those, I'm going to kind of go a little fast through some of the home and community-based service spending plan items, just because there's so many. But we've provided links in the PowerPoint, and all information is available on the department's website. Just because I know you guys all probably want to get to the discussion portion of this as well and ask questions and engage. So, really, starting with the home and community-based services spending plan, it really is an opportunity where enhanced federal funding has really provided California with a large opportunity to make pretty substantial investments in the program, especially where we are serving some of our most vulnerable Californians. And so it is a very comprehensive proposal where multiple departments participated. It includes 28 initiatives totaling around $3 billion in enhanced federal funding, and $4.6 billion total funds, so extensive. And I'll walk through each of the main categories of services. You'll see that it includes a focus on workforce, navigation services, transitions, a variety of services, and then really on the infrastructure and support. Next slide. So really starting on the workforce side of things. Oh, and I should mention, not all of these are led by DHCS. I really want to acknowledge that there are 7 departments within CalHHS leading amazing work in this space. And really just want to acknowledge that. So the Department of Social Services, of course, the Department of Aging, Department of Developmental Disabilities, Public Health, Rehabilitation, and the Department of Healthcare Access Information, now known as HCI, formerly as OSHPD. And I'm still getting that one drilled into my head. So if I say OSHPD, I greatly apologize, but I would flag that particular piece for all. So on workforce, one of the pieces we knew when the opportunity came that really critical for us to ensure that we can, maintain and expand our home and community-based services direct workforce. And so you'll see listed here a number of initiatives that really recognizes this workforce and the need for it to be both cultural and linguistically, available to all individuals. And really making sure that we are enhancing that within the home and community-based services environment. And you'll see a variety of initiatives, both across the home IHSS area, as well as non-IHSS. As you all are very aware, we have a large number of what we call 1915C waivers and or other kind of long-term services and supports where we have a very robust network. And so you'll see complementary proposals here where there's a career pathways within IHSS, and there's a similar but different proposal around training and stipends for non-IHSS workers and workforce. We did care economy payments for all of our Hcbs workers. We're in the process of doing these, just to be clear, and then really working on the clinical workforce as well. So trying to find this balance of how do we really support. And then one of the unique things within the way CMS approached the home and community-based services spending plan is they really expanded it across all behavioral health services, which they consider, or dominantly the rehabilitation services within behavioral health to be directly tied here, as well as services, for example, for individuals who are experiencing homelessness. So you will see, as an example, some what we call providing access and transforming health funds for individuals who are both homeless or in Hcbs settings. And so really trying to expand. And then, of course, an initiative around traumatic brain injuries as well. Next slide. The next bucket of initiatives is really around focusing on the navigation portions of home and community-based services. Here, really focusing to improve access to Hcbs services. The initiatives work to kind of development a variety of statewide systems, including various screening and assessment tools, referrals and navigation systems, coordination, and you'll see even, outreach campaigns. So a variety of initiatives here ranging from no wrong door systems to dementia aware and geriatric dementia continuing education, language access, and what we call CalBridge, which is a behavioral health pilot as well. So you'll really see the variety of services built within here, but really trying to increase those navigation points across the system and making sure those transitions are happening smoothly. Next slide. Speaking of transitions, a really important part of home and community-based services. So, really here, I think a bulk of what a lot of people spend their time on is twofold, right? Making sure that individuals who reside in the community can reside in the community and have the appropriate amount of wraparound services around them, that those transitions can smoothly happen, and that they have the needed services around them to be able to successfully and safely live in the community. So here you will see a variety of initiatives focused on, those types of transitions. You will see that there is going to be some community-based residential continuum pilots. As you may or may not be tracking, there's a variety of dollars out there right now to really increase the footprint in regards to, assisted living type environments, RCFEs and others, where we want to think about how do we comprehensively build models that really aim to make those transitions successful, or to test bundles of services within one payment delivery. And so we will be piloting those types of things, expanding here the assisted living waiver wait list, focusing on housing and homelessness incentive programs with a crossover lens of individuals who are older adults as well as individuals with disabilities, and then really focusing on the community care expansion program as well. DHCS and DSS partnering in that with our behavioral health continuum infrastructure proposal as well. So really maximizing those services to allow for those smooth transitions for individuals who are older adults with disabilities, homeless individuals, and really finding those opportunities to stay safely in the community. Next slide. And then a laundry list of supports. And really this is aimed at making sure that we were putting various infrastructure investments in place to really grow home and community-based services. You'll see a long list there. I'm not going to read them all, but they are there. But really, really important infrastructure investments just to make sure that we are building for the long term and not just the short term. And so really excited about many of the investments within the home and community-based service plan. Next slide. Oh, I guess we have, I don't know if I missed up on our slides. I should have said next slide, but here's the list of the support services. Sorry for that particular piece. Next slide. All right, so to dig into CalAIM. So here we are very excited to sit here in 2022 to say that we have an approved 1115 and 1915B waiver in California. We at the Department of Healthcare Services led extensive discussions and negotiations with CMS in regards to this waiver. And while it is very large, it incorporates all the various components of CalAIM. For today's presentation, I'm going to focus on a subset of those proposals to highlight them for you. Next slide. Perfect. So really, CalAIM is really meant to transform our Medi-Cal delivery system. Everybody knows in Medi-Cal, the system, you get a BIC card to enroll into Medi-Cal, and then you could be accessing anywhere from 6 or 7 plus different delivery systems at any given time. Medi-Cal managed care plan, our mental health plan, substance use, dental, IHSS. If you're a child with complex medical conditions, CCS. So it really just expands across, and really thinking about how we bring those things together, that while we may not be able to, break down the silos of those things, really thinking about how we make our system more integrated and more focused on the needs of the whole person. And so we're really trying to reduce some of that variation that we've seen across the state and wrap around services that really meet all of the needs of our beneficiaries. It really focuses on engaging with providers and trusted partners to do this, including our managed care plans. It focuses on really expanding community supports and being proactive, a little bit more upstream in the system, not just waiting for someone to be in crisis or to be at an institutional, in an institution, really getting more upstream and making sure we're building the full continuum for people from, birth to dignified end of life, and making sure we span all of our resources across that. Next slide. So this is a laundry list of all the various CalAIM initiatives that were approved in the waiver. I'm not going to read it, but it's there for you to be available. You can see it's really across all of our various delivery systems where we made pretty substantive changes, and really look forward to rolling this out over the next few years to really move the needle in regards to services in Medi-Cal. Next slide. So enhanced care management, this is one of the cornerstones of CalAIM. It's really around, leveraging individuals who have, really complex, needs, making sure that they're getting really intensive enhanced care coordination services. You'll often hear us describe this. This is not the type of service where a case manager calls somebody on their phone. This is meant to be outside of the four walls of healthcare. So where an individual is going into someone's home or meeting them on the street. We've identified a list of what we call priority populations. And really that is to say, the highest need individuals, people who are at an institutional level of care that want to transition into the community, or somebody in the community that without additional services may need to go into an institutional level of care, and trying to keep them to remain safely in the community as they would like to. It also is for individuals experiencing homelessness, or individuals who are high utilizers. So really the idea behind enhanced care management is your most complex beneficiaries who need a higher level touch, and then across systems. It's not just their medical services, but all the social services that they may need, and really coordinating all of those various aspects. Next slide. So here you'll see, two of the populations that really have a crossover here, but many intersections. So individuals at risk of institutionalization who are eligible for long-term care services, who in the absence of those services and supports would otherwise require care for a 90-day consecutive, or for 90 consecutive days or more. And then you also see here someone who is in a nursing facility resident who is a strong candidate to successfully transition back to the community. So we're trying to do both prevention as well as transitions with these enhanced care management. And you'll see a lot of this in some of our 1915C waivers. One of the nice things about it being in the authority that we were able to get is it lets us engage with someone who's not only at an institutional level of care, which is really important. Oftentimes when you're in a 1915C waiver, you have to meet an institutional level of care. There are community enrollments as well, but you're still at that institutional level of care. This gives us more flexibility in who we target to be more upstream and to really allow us to do some of that. Next slide. The same concept exists with the community supports. So you'll see when I go through some of the community supports, there's 14 of them that were approved. These are things that are otherwise what we call in lieu of another state plan service. So an inpatient stay, an emergency room visit, a skilled nursing facility stay, where we're really providing alternative services to somebody that, would otherwise be, in a more costly environment. They have to be medically appropriate and cost effective. And we had to do a lot of conversations with CMS to get them approved. And you'll notice that many of the things on the list really include things like that would normally you would see in a 1915C waiver with various wrap services for somebody, but allowing that individual to receive them. It goes through the managed care plan, to be clear. If the managed care plan has opted to pick up these community supports. But again, it doesn't necessarily have to be at the institutional level of care, which you often see in those other waivers, but it really allows you to, just as long as it's medically appropriate and cost effective through the evaluation of that individual by a provider, that we would be able to provide those services. So I'll give you some examples. Perfect. Oh, yep, you're good. Thank you so much. you know, one of the examples is while we pay for the enhanced care management for somebody at either at risk of institutionalization or transitioning home, this community support would actually pay for somebody to reside in an assisted living facility as well. And oftentimes there's wrap services. Now Medicaid can't pay for room and board, so we're not changing any of those rules, just to be really transparent with everyone. But it does allow for someone to transition, and oftentimes where there's that wrap payment available or required for somebody, it would be able to be covered with these community supports, as long as the managed care plan, of course, is offering this particular service. Next slide. Also will pay for those transitions. So say somebody is in a skilled nursing facility and you wanted to, and they were, you know, identified as a good candidate that could safely reside in the community, and paying for those transitions. So something most people may know here is Money Follows the Person, or CCT in California, really making that available statewide, and really allowing for those transitions to happen, and then reimbursing for those transitions home, oftentimes for individuals or in an environment. So really happy to see this approved by CMS to allow just mass flexibility for California to meet the needs of individuals. Next slide. You also here see respite services. So this is respite for caregivers, and it is available both within someone's home as well as in a facility. So the combination of both is available. We have something separate called, you know, recuperative care, which is medical respite. And it looks like that may be the slide we have here. I would just mention what we should have included is also our caregiver respite. So we have both for someone, for example, who's experiencing homelessness, we cover recuperative care or medical respite, but we also have caregiver respite for somebody who, for example, may have dementia, Alzheimer's, or other, or a very child with really complex medical conditions, and then they're needing someone to come into the home, give them reprieve for a period of time. That would be allowable if the managed care plan is offering it. Next slide. We also are offering personal care and Homemaker services. What I would say here is this is separate and apart from IHSS, just to be really clear. So just like we do in our home and community-based alternatives waiver, where we provide additional personal care services above and beyond what IHSS covers, the same concept is what we are talking about here. And so if somebody has maxed out their IHSS but need a little bit more to reside safely in the community, these community supports would be able to cover that as well, especially for somebody who's, for example, not enrolled in a 1915C waiver. And that's something I should make really clear here. You can't receive these community supports and actually be enrolled in a 1915C waiver. So this is for someone not otherwise enrolled in those waivers. And that's a good clarifying piece for me to add. The next one here is around home modifications. So keeping someone safely residing in their home and making sure that, you know, if they need a bar in their shower so they don't slip, or a ramp or modifications needed, these would be available to be implemented under these community supports. So those were some of the community supports. As I mentioned, there's 14. There's also a robust list of housing services, navigation services, deposit and liaison services, and medically tailored and meals and medically supported foods. So encourage you, we gave you all the links in the presentation to navigate all of our various CalAIM pieces. I think the next big part that I would mention is, you know, we plan on carving in long-term care to manage care statewide January 1, 2023. So currently we have long-term care carved into our managed care plan in 27 counties, including 7 CCI counties and 20 additional COES counties, which is our county organized health systems. Those are counties where we have one plan currently providing services in that county. And then starting in 2023, we will have managed care in the remaining 31 counties across the entire state of California. So all managed care plans responsible for covering long-term care. It's why it was so important to make sure the community supports gave the managed care plans all the tools and pieces that they need to be able to have the responsibility of that carved in. And we heard a lot from many CCI counties who have had it carved in for a long time, and COES counties, just the importance of needing that variety of long-term services and supports to support individuals through the full continuum of care. We have been leading a large number of collaborative meetings around this carve-in. We know it is a large change for many people. And so our teams have been actively meeting with people and will continue to meet with people throughout 2022 to engage and provide feedback to us and to ensure that we do this right. Next slide. All right, dual eligibles. So here we also have announced that we are making a pretty large change. So effective 2022, we are moving to providing a more integrated experience for dual eligible individuals, where we have permitted Medicare plan choice to drive Medi-Cal plan choice. That is a phase-in over time. So in certain counties where a member Medi-Cal plan choice will align with their Medicare Advantage or D-SNP. So really what we're doing here is if somebody picks we're having Medicare drive their Medi-Cal plan choice alignment. We're really wanting direct aligned enrollment for those services, which really starts in January of 23. We'll have exclusively aligned enrollment. So in our CCI counties, somebody who selects a Medicare Advantage plan, if there is also a Medi-Cal managed care plan, which there'll be a D-SNP in all of those counties, we would automatically enroll that individual so that there is integrated care for those beneficiaries. And then we are planning to roll out our D-SNP proposal to the non-CCI counties in later years. I think it's scheduled for 2026, if I believe that's correct. So I think I might have got ahead of the slides a little bit there. So I think we're good on that one. Next slide. All right. So I know that was a lot of information in a short amount of time. I think at the end of the day, really we feel that both the Hcbs spending plan and the CalAIM proposal jointly really provide a really large opportunity to provide more coordinated, more integrated, managed long-term services supports across the entire state of California. And it won't happen overnight, I can promise you all that. But we do know and have a very large commitment from our managed care plans to bring up these community supports over the next few years. And we actually have a schedule on our website for every single county, so you can see where those community supports are coming up. And they can come up every 6 months. So we have a chunk that went live January 1 of 22. There's another group of them coming up in July of 22. And then 23, so forth. And we've only listed the schedule currently online until 24, but it just really shows a large commitment. And you will see that some of the managed care plans aren't bringing up some of the more kind of routine MLTSS or Hcbs services until later, closer to the 23. And I think that really has to do with the alignment of the long-term care being carved in and making sure they have time to kind of build those relationships over time. As you would imagine, it would be very hard for a plan to bring up 14 new services at one time overnight. And so really seeing a phase in at this point in regards to bringing those services in. So I will stop there. And I don't know how you kind of want to do questions or if you're going to go right into discussion. And I can stay for that discussion part as well, if helpful.
Great. Wonderful. Well, JC, thank you so much. It is always fantastic to hear your concise summaries of so much work that's going on. We're going to lead a little bit of a Q&A and discussion. There's a few members that will be kind of a reactor panel. Before we begin, I just wanted to see if Patty from Justice and Aging wants to make a few remarks before we start our facilitated discussion. Okay, I don't hear from Patty, so we will just keep going. JC, I just want to start first by thanking you for staying for some of the discussion, because I think there's just a lot of great questions and comments that the members will have. But I was wondering if, before we get into the discussion and Q&A from all the members, a lot of what you touched on relies on the importance for this community of building partnerships across aging, across disability, but also with the managed care plans, and particularly in building out capacity in developing community supports. And for much of this community, the relationships haven't been built, with the managed care entities. At the same time, I know there's tremendous opportunities and funding and investments being placed in trying to build capacity statewide through the PATH funds, as an example. I was wondering if you could talk, when we go into Q&A right now, if you could first talk about kind of the opportunities for infrastructure development, and really importantly, what's your advice to our local partners on how they can engage and be part of it, so that they too are part of this opportunity to weave in social services and supports into our Medi-Cal delivery system?
A great question. So, and we should have had a slide on it. I don't know why we forgot to put PATH in. It's so exciting. So, one of the things that we're doing is, when you're making this much change in a program, we know that we need to have new partners. And we know that they're often going to be partners who maybe aren't used to Medicaid rules. And they may not be used to working with managed care plans. So we did do some planning in regards to that to anticipate. And one of the things that we did is put in some PATH funds into the waiver, with CMS did approve, and it allows us to provide direct grants to providers. This is directly from the Department of Healthcare Services to providers. It's actually not through the conduit of managed care plans. Now, you do have to have a commitment to be a partner with the managed care plan, just to be clear, because the idea is to build the infrastructure in partnership where there's a contract with the managed care plan, but where we will be able to help support providers take on, whether it's the enhanced care management portion or those various community supports. And to be able to fund them. Maybe it's for example, they provide a similar service, but they only have a capacity within their program for 100, and they want to grow to be able to provide services to 300. But to do that, they need some dollars in some infrastructure, whether it's systems or workforce for a year. We know that it's going to be really hard for providers to take risk to do some of these things. And so we wanted to remove that as a barrier and provide grants directly to providers. And it would be for any of the community supports. Now, the caveat is where the managed care plan is offering that or plans to offer it, right? And where there's a commitment of a partnership, because we want to fund providers who are going to be a part of the Medi-Cal network. And providing services directly in partnership with the managed care plan. But we're also, with some of those PATH funds, we'll be funding local collaboration dollars, so all the right people can get to the table and have those really important conversations, as well as some technical assistance. So say you're a smaller organization, you're like, I don't even know where to start. You would be able to draw down some technical assistance funds where you could bring on a consultant or somebody who could help you build that roadmap. And these dollars can go from for technical assistance, workforce training, systems, et cetera. Because if we really want to have long-term services and supports statewide, we know that it's an important investment. And so, our proposal to CMS was about $1.8 billion for this investment. A portion of that is dedicated to our justice proposal in CalAIM, but the majority of that is really focused on making these community supports, enhanced care management successful. So hopefully I answered your question, Sarah.
Yeah, no, that was super helpful. And so I'm assuming that, I know DHCS has put out some information on the PATH and the next steps. So we will find the links and put them up in the chat or the Q&A so people can have them. I think it's part of the beginning of a very important conversation for this community going forward. So what I want to do is, I know there's several of you who, a few of you who will be part of a reactor panel, but maybe what we'll do is we're going to intersperse some of the questions with the reactor panel, because I want to make sure we can get to some of the hands that are raised. So I want to start first with Janie Whiteford, who is with the California In-Home Supportive Services Consumer Alliance. Welcome, Janie. And then we'll follow with Nina and then Sherry Burns. So welcome, Janie.
Thanks. Nice to see you, Sarah. Couple of two questions. One, what is your outreach method, and have you started to the counties and to not necessarily the nonprofit organizations that would be interested in this and the plans, but the actual county involvement itself, because they're not on this call, and there's a lot of folks that aren't going to know what's going on with that at all. And my next question is, what are we going to do about the rural communities that do not have the infrastructure to provide a lot of these services? And can they join together? Do you have any plans to help them get this going?
That's great questions. So on the first one, since we just got approval from CMS, we are rapidly working to build the infrastructure for the grants, right? We have to build applications and parameters, and technically we still are negotiating some of the protocols with CMS, just to be really clear. But once we wrap those things up, we are also in the process of identifying a third-party administrator who can help us touch all the parts of the state. Here at DHCS, we need people who can be on the ground in Southern California, Central Valley, Central Coast, Northern California, rural areas, for example, right? So we are trying and we'll be working to identify a TPA who can help us get the word out, do the outreach, engage the right people. And so we are working on those efforts right now. And yes, we very much want rural communities to participate. It's why we ended up adding in sectioning a portion of dollars for technical assistance so they could afford to bring a consultant in or to do some of those things for these infrastructure dollars that would be available for them where they may not otherwise have staff that can dedicate a portion of time to build an application and do something, right? So we want to be flexible. So we've tried to make sure that it can meet the needs of the diverse population in California.
Thank you.
Thank you so much, JC. And I just wanted to plug for everybody here, there will be a webinar on March 9th from 10 to 11, a 1-hour webinar focusing in on this issue of partnership building across managed care health plans and aging and disability providers in the community level to figure out where are some of the promising practices and how can you all play a role in the rollout of CalAIM. So I'm going to go first to Nina and then to Sherry Burns and then to a few of our reactor panelists. So Nina Weiler-Harwell from AARP, take it away.
Thanks, Sarah. So I have a couple of questions. I'm really trying to check my understanding. Some things that I heard said, one is I thought I heard JC say that the assisted living waiver would not cover room and board, which kind of rings a bell based on somebody I was helping in Tennessee. But could you explain, is that what you said? Did I misunderstand you?
So we cannot use Medicaid dollars to pay for room and board. It's a strict rule. And so while someone can use their SSI, and oftentimes the waivers will pay for wrap services around someone, but we are not allowed to pay for actual room and board.
Okay, yeah, that would definitely, I could see how that would pose a problem for somebody who's extremely low income. That's the first question. Then the next question I had, also checking my understanding, is I thought I heard you say that there would be respite coverage for caregivers if the plans offer it. Did I hear that correctly? So it's optional?
It's a great clarifying question. So one of the things around community supports is they are at the option of the managed care plan, which is why we have posted all managed care plans and by county and managed care plan of who's covering what. Managed care plans are also required to indicate on their public website which of the community supports that they cover, and then to put it in their member handbook so that the members are very aware of around what is being covered in their particular county. But since we're building it up over time, it does vary at this point. The goal, of course, is to get all community supports in every county across the state of California. That will take time, but we don't want to, we want to be able to let the counties who want to come out strong, and really get services out there. So that's what I meant by that. I just wanted to caveat, this is a little bit different than a mandatory Medicaid benefit. that is available in every county statewide. It is at the election of the managed care plan to offer it. And then we try to make it very transparent. And then once they do offer it, all of the protections of a benefit kick in, but they do have to elect it under federal regulations.
Okay.
Great.
And I know that in the future, just really quick, so other folks can talk, and I've spoken to your staff as well about the importance of a universal caregiver assessment, bringing those services in, but thank you for the clarification.
Of course.
Thank you so much, Nina, for that. And I'm going to turn now to Sherry Burns, who is Executive Director of the Silicon Valley Independent Living Centers. And Sherry has a lot of experience in working directly at the local level with Santa Clara Valley Health Plan and the network there to try and build capacity. So we'd love to hear from you, Sherry, on kind of what you see as some lessons learned and other points that you'd like to note.
Yeah, thank you. I appreciate that, Sarah. And thank you, JC, for the excellent presentation and overview. A lot of information and a lot happening. Sarah's kind of kicked us off here with talking about how to expand a lot of the partnerships, I think, beyond the traditional medical systems and healthcare systems. You talked a lot about the importance of community supports. I, for one, really appreciate changing the term from in lieu of services to community supports because it makes more sense. It incorporates a lot of the social determinants of health and peer support being part of that. And to that point is that the Centers for Independent Living, and I operate the one in Santa Clara County, have been doing a lot of transition services over the years, along with many other services. We provide anywhere between 8 and 12 different kinds of services, all which fit within the 5 MPA goals. It's been, somewhat still difficult over the past year or two for a lot of the community-based organizations and specifically independent living centers to get those partnerships going with the MCOs in their area, excluding those of us that have had the wonderful opportunity of having relationships already built around the CCT program, as you mentioned earlier. And so some of us have already, had long-term established relationships with our managed care plans because of that coordinated service of transitioning folks out under CCT. And plus we also had the Medi-Cal billing background also, which is, it can be daunting for a small nonprofit to get into. So I was actually excited to hear you say that there is new funding and opportunities, grant funding and support opportunities for some of the smaller CBOs and specifically perhaps independent living centers to build their capacity to have some of those relationships, or at least start those relationships with their managed care entities. And would like to hear a little bit more about, how that can work, when that's going to actually roll out. We've been kind of hearing a little bit about that happening, but when are we actually going to get in kind of, I guess, the meat of being able to, encourage our local CBOs, the independent living centers across the state, to access some of those funds and technical assistance in order to start to build some of those partnerships with their local MCOs.
Yeah, so I think, the funds we're anticipating will start flowing in the third quarter of 22. So after July is what we're currently planning for. Once we get the third party administrator in, we'll fine tune those timelines, but that's what we're currently planning for purposes of applications starting to be available. But again, the third party needs to be identified and we need to roll some things out. So I'd say, within the third quarter of this year. As I mentioned earlier, it will have 3 main components: collaborative dollars, technical assistance dollars, and direct grant dollars for providers. And that was built intentionally to allow for local collaboration. We are doing some listening sessions and have been, many of you on this, I know, have participated in some of those just to make sure we understand the various needs, but it would be across all community supports. And so, so I think, more to come. We will, when we kind of have information, we will share it. The team is feverishly working to finalize the CMS protocols first, which is a CMS requirement, to make sure they understand the parameters for the applications, and then we can do the application. So we're kind of internal, getting feedback from people, and we're hoping to hit the ground running in the third quarter of this year.
Okay, wonderful. Thank you so much. And the second question I had was, like any new project, and this one being definitely a huge one, undertaking, is that in order to, make sure that we are on course and that we're able to correct course if we get off or have some difficulties along the way, is to incorporate evaluations and assessment and making those changes. And I have not heard anything yet about plans to develop advisory councils through the managed care plans at the local level. I would certainly love to have a mandate for that, but in lieu of that, strong encouragement that the MCOs actually develop advisory councils that include beneficiaries directly to be part of those advisory councils, and so that they can get feedback from the providers that they've engaged for the community supports, as well as enhanced care management, as well as the beneficiaries that are participating in these programs and services. Is that something that's on the radar yet?
So a few pieces there. You're touching in, there's a lot of things going on at the department, but I'll definitely take it back in regards to what's currently there. As you probably know, managed care plans have a number of advisory councils that they're required to do today, including some that have very clear parameters. One of the things that we just announced in our managed care plan procurement today, which won't kick in until 2024, is requiring families and members to be included in many of those advisory committees. So that's down the road, just to be clear, but really trying to make sure that we are taking that lens. And then even us at the department will be having and launching a consumer-focused advisory committee. We've never had one at DHCS, believe it or not, which is kind of crazy to think about, but Director Boss made it very clear it's very important, and we will be instituting that here at the department as well. So I think there's opportunities there. From an evaluation perspective, just to be clear, we get regular reporting from managed care plans, and we will be required under the 1115 and 1915B waivers to do a very robust independent evaluation of both enhanced care management and community supports. And so there will be opportunities from an evaluation, but in regards to that engagement, I'll take it back and just make sure it's really clear. Our expectation is to work locally with people and to engage all of the right people at the table.
Thank you. That's very encouraging. Really appreciate it. Thanks.
Thank you so much, JC. And I think that's an important point you made about hearing from consumers. And we actually have a few consumers on this committee. So we are excited to hear from Michelle Rousey and Peter Mendoza in just a moment. But first, just going in order of the hands raised, Megan Burke, my former colleague, a senior analyst at the SCAN Foundation, has her hand raised. And after Megan, we'll turn it over to Michelle Rousey.
Great.
Thank you, Sarah. And thank you, JC, for your presentation today. I was just kind of thinking along the lines of, well, actually just your response now, talking about the robust evaluation, and appreciate that you guys have the spreadsheet listing, the different community supports and what plans are providing them. On the flip side, as these services are being provided, will there be an opportunity for people to see the data as far as who's receiving those services and where, to really be able to help inform, I think, that evaluation, as well as, discussions that we would have, I think, as a group about, work going forward and extending access to home and community-based services.
Yeah, so one of the things that we agreed to in AB 133 last year, which is essentially where almost all things CalAIM codified, is to have data reporting and to slice it by, age and ethnicity, all those various important indicators. And so, yeah, we will, once we start getting encounter data in, and over the next few years, be reporting that. So we're thinking through how we modify our managed care plan dashboards that we post on a very regular basis, and or other reporting areas where we can make that data available for people. And so once we start getting that in, we'll be able to share that at some point in the future.
Great. Thank you so much, JC. And I'm happy to turn it over now to Michelle Rousey, who is a really critical voice. She's been active in these conversations. I remember, but way back when, Michelle, on the Olmstead Advisory Committee, so appreciated the perspective you provide. And you had shared that you wanted to express some of the feedback you have in terms of the last transition in the to Medi-Cal managed care and some questions that you have for JC.
Yeah, can you hear me?
Yes.
Okay. Yeah, I am concerned. The last Medi-Cal mass enrollment into managed care plans was not as smooth as we probably would have liked as a state. And I'm concerned that we haven't learned our lessons in forcing people into managed care plans without having a robust plan statewide for that to happen. And I'm concerned with leadership that the consumer voices that, yeah, some of the managed care plans, they do have those consumer voices, but I think we need it at a robust state level that is over all of it, and having that consumer voice there is so important. And have we learned our lessons? You know, are we going to repeat what happened years ago? And if so, it's a sad day for California.
Thank you for your comments. So a few pieces. We agree with you 100% at a state level consumer committee. And so we will be forming that this year, led by the department, where we'll be polling in consumers across the entire state of California. So we just want to 100% say we hear you and we agree. And then on the lessons learned, we have spent a lot of time wrapping our arms around all of the lessons learned. And we are working on how do we package that up for all of the new managed care plans as well. And we are also having some smaller advisory groups at the state to really hear from providers and advocates around these changes. And so we're very committed to trying not to relive previous hiccups, for lack of a better description. And so we will, I will take this back to the team to make sure that they're tracking as well, and really appreciate your comments.
And as a dual, I think it's important that, you know, for that transition, that you have as many people who currently have multi-county services be involved in some of that transition. My biggest concern is I lose some of my out of county services by having under managed care. So thank you.
Of course, thank you.
Thank you so much, Michelle. We really appreciate hearing from you. And I'm really pleased that Shereen McSpadden is here. She used to be, you know, the director of the San Francisco Area Agency on Aging, and now she's executive director of the San Francisco Department of Homelessness and Supportive Housing. Such an important perspective you provide, because you worked a lot when you were a AAA director and trying to build the relationships with Medi-Cal managed care plans. And now in your role, kind of looking at it from the housing perspective, would love to hear your thoughts, Shereen, on kind of emerging issues and points to highlight at this moment.
That's a lot. Thanks, Sarah. JC, thanks for your presentation, and it's been really great to follow the discussion afterward. So a couple things, I guess. One of them is that when I was the director of the Department of Disability and Aging in San Francisco, I worked really closely with a lot of our nonprofits, and then worked at the California Association of Area Agencies on Aging to really think about how Older Americans Act programs fit in with kind of managed care in general, and fit in specifically into programs like CalAIM. I mean, this was before, so it was a previous version. But one of the things that is challenging is that we have so many small organizations, and you mentioned that there's going to be support for them and training and grants, but you know, unless you can really get the bang for the buck, unless you can really pull together and get the scale that you need, it's really challenging for single organizations to play and to really get the attention that managed care and managed care isn't going to get the scale they need. And I'm curious to know if there is an opportunity for, say, a statewide organization that's working with smaller organizations that are providing, you know, services together to engage with you, so that we could figure out how that might work and be split across the managed care plans, because it's just really hard and very daunting to figure out otherwise. And kind of goes back to what Michelle said about, you know, she referenced cross-county issues. It's a really big issue when you start thinking about some of the services that are provided by nonprofits and counties too, serving older adults and people with disabilities, you know, when they're doing their own care coordination programs. When you're thinking about the importance of social engagement or technology or any of the many things that AAAs provide, I'm just curious about how that can fit in a way that ultimately makes sense. I know it's been done, it's been done a little bit, but I think it's only the tip of the iceberg. And I think that there could be a much more robust way that that AAAs could be a part of this. And then I'm also just want to also say that, you know, also just thinking about homelessness, people living in permanent supportive housing, people living in shelter, just curious about how CalAIM, I mean, we've done some work in San Francisco, so I'm not asking a question without completely understanding the answer, but just, you know, what would you say about how CalAIM can really help support older people and people with disabilities who are experiencing homelessness, who are in our shelter system or who are in permanent supportive housing?
Sure. I will tackle both of those. So I think the first one, I was thinking as you're talking that you must be sitting on the listening to our brainstorming session. So we are actually working to find someone who can help us create an inventory of various community-based organizations and or associations that we can use to communicate the funding opportunities to, because there's so many, like you said, across the state of California, and some are small and won't be tracking this meeting today or these conversations, which is fair to those organizations, to be clear. And so we are trying to noodle over how do we create a new communication path we've never had, just to be clear, at the Department of Healthcare Services. I just want to be honest with you on that front. Of course, we work with a number of community-based organizations depending on the services we're talking about, but it's going to be really important as those new partners come to bear, right? And where there's an association, beautiful. But right now, with some of the services we're talking about, there's not, right? And so it's how do we identify those individuals so we can effectively communicate? So we actually are noodling over a scope of work that is somewhere in that vein. So it very much resonates to how we can get the word out and information out to all the right people. I think the other piece I would flag on the housing and homelessness piece. So there are, within CalAIM, there are so many components that really help individuals who are experiencing homelessness. There is the dedicated enhanced care management bucket that essentially requires you be on the street, right? Out and engaged with people, or in people's homes or in shelters, for example, to go outside of the four walls, not waiting for someone experiencing homelessness to show up at a clinic, right? And so that's really important. Then we have a suite of housing services. So we have services for housing transition, so paying for that housing transition bundle, housing deposits. So if someone has identified housing, we can pay for last month's rent and utility pieces there, allowable within the federal memo, of course. And then liaison services. So when someone gets housed, making sure they can stay housed and that they have an environment that allows them to be successful, and not a lot of lessons learned from whole person care and other pilots. But we also have a suite of services of recuperative care. So somebody who's in an inpatient stay, so someone experiencing homelessness is an older adult, and they're in an inpatient stay, instead of just discharging them to the street or them languishing in an inpatient bed for a very extensive period of time, which we all know happens, being able to transition them safely into recuperative care, which is 90 days of clinically enriched housing. The idea there is you also have a captive audience where maybe you can get them into other social services. You can get them connected to some temporary housing, or you can get them on a glide path We have another version of that for what's called post-hospitalization stabilization housing. So that's a longer period of time. So slightly higher acuity, but a 6-month window for somebody needing services available. And then we're also included community supports, which is like day habilitation services, right? Somewhere, a center where they can go to be able to access resources, training, tools, etc. So those are all some of the supports that are available for individuals experiencing homelessness who are in shelters or who are at severe risk of homeless. And so hopefully that helps. Just so others are tracking, we also recently issued, well, recently, it was last year in July, but feels like it was yesterday,
Yes.
a guidance around how to bill for street medicine services effectively, the codes and the modifiers that should be used so that that can be available, as well as how to maximize, the hospital presumptive eligibility in the community so people can enroll homeless individuals easily into Medi-Cal. So we're trying to really make sure the system can meet the needs of that population. So hopefully I answered all your questions.
Thank you so much, JC. Really important elements highlighting on the housing focus. So I'm really pleased that we will hear now from Sylvia Ye, who is with the Friends of Children with Special Needs. We haven't heard a lot yet from our developmentally disabled partners, so it's really important to understand kind of the issues you see in terms of how this is aligning with the regional center work. So thank you, Sylvia. And after your question, we will hear from our friend Peter Mendoza, who is representing LTSS consumers as well. And then last but not least, Michael Bleck. I just want to do a quick time check. Are we okay, Susan and JC, is it okay with you if we go till 3:40?
Yes, I can do until 3:40. That's good.
Awesome. Thank you. We want to take every minute we can get with you. So Sylvia, thank you for being here.
Thank you so much. Hi, again, this is Sylvia Ye from Friends of Children with Special Needs, and we are located in Alameda County and Santa Clara County. And the issues that we are facing the most is that no providers want to, or no, very few providers willing to take Medi-Cal clients on that. So we're hoping that the reimbursement rate through this the enhanced management care, that can have more providers, health providers willing to take Medi-Cal clients on that. And second things, just like Sherry said about the very exciting for the grant opportunities for the CBOs on that. And I want to emphasize on the CBOs have the capacity of the language to help the non-English speaking families can really understand and access this new the management care. Thank you.
Thank you.
Wonderful. So now I'd love to turn it over to Peter Mendoza, who works with the State Council on Developmental Disabilities, but is here as a LTSS consumer. So Peter, take it away.
Thank you very much. Great to be here. Couple of questions. I want to talk about equity. First, I want to commend everybody who's been working so hard to really improve LTSS systems throughout California. I was wondering, is there any work being done to make sure that the information that's being put out to people with disabilities, older adults, and families is written in language that's easy for folks to navigate? And I also want to make sure that since not all services are provided by various managed care agencies, and that people have enough information to choose which agency is best for them. And also, we're just going to check to see about what's being done to make sure that folks can, when there is a dispute or a misunderstanding, that folks have a way to access their rights and remedies if they're being denied a benefit or it's not working for them. And just also, I think it's great to have CBOs like independent living centers involved. I really encourage that. What's being done to sort of streamline the administrative process to make sure it's easy for community-based agencies to work in partnership with managed care? And will there be a role for the aging and ADRC is the aging the ADRC is in navigating and assisting folks in connecting with managed care entities.
Okay, I tried to write down all your questions, so I'm going to try to get you responses to all of them. The short answer is yes, all providers providing these services will need to meet all language access requirements of the department. And we have made that very clear in all the guidance that has gone out. On the provider choice piece, so to the degree that a managed care plan has contracts with multiple providers providing something, then yes, beneficiaries have the ability to choose. We're hoping that there will be multiple providers doing these services. Depending on the county, I would just flag it may vary, just to be clear, especially in some of the rural areas where it may be harder for us to get multiple providers in play. When it comes to the appeals or grievances rights, so yes, for the community supports, even though it's not technically a full mandatory Medicaid benefit, we have put in protections around due process and notifying individuals if something is not approved in the process to how to mitigate that if there is a misunderstanding, as I think you called it, or a hiccup there. And then I think the last piece was around the ADRCs. And I think, broadly managed care plans, especially those are in CCI, I've learned, you have to have really key partnerships to be successful. And so we will do what we can to make sure it's really clear who are those key partners and community partners that they should be linking up with. They also will need to do a lot of that heavy lifting. So it's a great flag in regards to those local, really important local connections that should be happening. I hope I hit them all. I tried to write them down as fast as I could.
You did very well, and I know I can be kind of lengthy. Just one more thing in closing. It's just really important that we have incentives to really make sure that we're supporting everyone, especially those of us with severe disabilities or older adults, especially in the rural underserved areas. I would hate to have somebody not be able to get a service that keeps them in the community fully independent or as independent as they're able to be because of difficulty serving a certain area. We don't want any part of our state, experiencing barriers as much as possible. So I would recommend some rate incentives to encourage services in some of the underserved areas or folks with severe disabilities and older adults.
Thank you. Oh,
yeah.
Sorry, go ahead, Jason.
I was just say, I agree with you, and we actually are going to be portioning funds available to make sure that they don't all get gobbled up by the large urban areas, but that there are funds available for the rural areas. I forgot to mention that earlier, but agree with you. We would love this to be statewide.
Right.
Thank you.
Thank you, Peter, for those great questions. And we have Michael Blecker with Swords to Plowshares, who has a question, and then Marty Emoto will close it up for us. And I just want to say, JC, this has been unbelievably helpful just getting this update. There's a number of themes that have emerged, and there's some questions that haven't been addressed yet in the chat, but we will collect all of those and follow up with our colleagues at partners at DHCS to see about responding. So
great.
Thank you for that. Okay, so Michael, welcome.
You see me?
We
Hello.
can hear you. Hi, we can hear you.
Okay, very good. So yeah, for us, we're and I want to echo what Shireen mentioned, but we're a nonprofit community-based organization, and for us, and we serve something like 500 homeless veterans, formerly homeless vets. So in permanent supportive housing. So we're operating with the Veterans Administration. That's another system, right? Where you have managed care, and then you have the VA, and there's always a challenge finding, determining or getting veterans eligible for Medicare. And that's been a problem because a lot of veterans who are living in permanent supportive housing, that's actually long-term housing, and that really represents, they have a great need for wraparound care, clinical supports, nutritional supports, nursing care, that kind of thing. And it's really difficult to get that kind of coverage they need, because so often, so few of them are eligible for Medi-Cal, right? So it's trying to figure out the two systems, the VA system, the Medicare system, and how you get the actual funding so you can bring in the clinicians that's what folks need.
Yeah, completely understand what you're raising. I would want to just clarify here, the services I walked through would only be available for someone who is enrolled in Medi-Cal, but completely understand the complexities it brings when you're braiding so many different payers. And so but did want to make sure I at least clarify that to make sure that's clear, but completely understand what you're saying.
Thank you.
Okay. Thank you, JC. Okay, and Marty Emoto, the one and only California Disability Community Action Network. Thank you, Marty.
Hey, thank you. And a family member, I'm an unpaid caregiver to a 29-year-old person with autism and Down syndrome living with me. He's also a Medi-Medi. First of all, JC, just a shout out to you and your team for this amazing work that you've been doing over the last couple of years. I've been participating in some of the stakeholder groups, but I don't think a lot of people, outside of those people who are participating, really understand how massive, how transforming this potentially is. And I think, for you to be the Medicaid state director now, I've worked with all your predecessors, and I'm sure I know you did too. They had to talk about cuts, or they talked about change that were really about cuts. And I think that leads to the other issue, and Michelle, you're raising it, and some others, is that we're going to have to do outreach, all of us, with our networks and our community-based associations and everywhere, the regional centers, everyone, to really let people understand what this is about, because not everyone understands. It's so massive. And by the way, this is happening when the other systems, Department of Aging, Department of Developmental Services, Department of Social Services, every one of these agencies are moving with massive changes within their own departments. At the same time, this is happening with CalAIM. And I've tried to explain it to different groups, but they just don't quite grasp how they see themselves in it. They see these wonderful titles, enhanced care management. They see all these great things, but they don't know or understand, how does that impact me? What will this mean to me at the end of the day? Should I put down what I do now and try to find out more information? And how hard should I work to find out more about this? And so we're all going to have to work with you. And I, just as Peter was saying, and Michelle, I think I'm looking at Gabriel right now. I think the regional centers are going to play a really important role in getting the word out and explaining how does this fit on a person-centered way to each individual that we're talking about across all the systems. Because at the end of the day, this has to be meaningful to the person that it's meant to help. And whether it's the provider, the individuals in the provider community-based organization, or the individuals like Alex who lives with me, how will it matter in his life? And so we need to partner with you. And, it's not going to, and the other thing, JC, and I think this, it's not going to be perfect, and it can't be perfect. But I think if we're working together, and this is so much different than the days when, Sarah, you were staffing the Olmsted Committee and we were fighting against cuts. And we never would have dreamed, in looking at Susan, that this type of change was going to ever happen while we were still living. And yet it's happening. And so whatever we can do, and with the caveat that we understand it's not going to be perfect. And then how do we work with you to do the outreach to all the various communities, the regional centers, the community-based organizations across California, the consumers, everybody, to get word out on what this means to each person and each family. But again, shout out to your team, because it's been going on for the last 3 years, and it wasn't easy, was it? So you had a name change in there once. You probably don't want to talk about that.
Marty, we don't bring up the name change. That's off limit.
Susan and I and Lydia, and we were talking about that. So thank you very much. I'll turn it back over to you, Sarah.
And I'll just say something real. I appreciate it, and I appreciate your participation over the long journey of CalAIM, and always good input. And we actually are trying to work through a communication strategy, because we agree, things like enhanced care management, or even some of the services around housing, get a lot of airtime, and those are really important. But there are so many other things in CalAIM that are so important. And how do we get that information out to the right people? And so I agree with you, and we are working on it, and we look forward to partnering with you on it, is what I would say. So thank you for that.
Well, JC, just a really big thank you to you and your team for the tremendous amount of work that has really gone into this transformational effort. We talked about a lot of important themes, really partnership building in so many levels, outreach and awareness. We're all part of this, so we need to engage our communities in being part of the capacity building and infrastructure, in building networks at the local level, and in ensuring that there is that strong consumer voice embedded. So what we can promise to you is that we will engage our communities and offer our assistance and supports however we can in rolling this out. So anything else from Susan or Patty, our co-chair, before we move on?
Couldn't add anything else. Thank you so much, JC, and to everyone for a very rich discussion. And we're going to take pieces of this back, and I'm sure you'll be hearing from us again. So thank you.
Great. All right, thank you guys.
Thank you. And apologies, Gabe. I know that you had wanted to ask a question at the very end, so we'll be sure to follow up and make sure there's opportunity to highlight the issues. I'd love to hear more from you. So thank you. Okay. Break. Susan, did you want to, who's segueing into the break? I wasn't sure.
I think Maria will explain. I think it's a 15-minute break. Is that right, Maria?
Thanks, Susan. It's a 10-minute break. So we will be back.
Sorry.
Well, we'll just say it's 3:45 and we will be back at 3:55. And I encourage committee members to mute their mics and turn off their cameras, get a stretch, get something to drink, and we'll see you soon. Hey, and we're at 3:55. So welcome back to our committee members. Welcome back to our ASL interpreters, closed captioners, and Susan, it looks like you've got your camera on, so I will let you take it from here.
All right, thanks again, Maria. And thank you, Sarah, for leading that conversation. That was just wonderful. And I just appreciate so much everyone's questions and participation and engagement, including in the chat. We'll be sure that anyone who didn't get a chance to speak with JC, that we follow up with you. And now we're going to move from, the simple topics of housing and Medi-Cal to another easy topic, transportation. We are so grateful to Avital Barnea, who's joining us today from the California Transportation Agency. Thank you for being part of today's meeting. We're really looking forward to hearing from you and to hearing from members of this committee and others who've been working diligently to bring some topics up for discussion. So Avital, are you here?
I am here.
Wonderful. Welcome. Welcome to you.
Thank you. Thank you. Can you hear me? Okay, great. All right. Well, thank you all so much. It's great to be with you. Thank you, Director Damaris and the Department of Aging, for inviting me to join you today to talk about transportation investments proposed in the governor's budget and other areas of progress that'll help improve transportation for older adults and people with disabilities. Again, my name is Avital Barnea, and I am the Deputy Secretary for Transportation Planning at the California State Transportation Agency. So we all know that transportation is an important component in all of our lives, and that includes older adults and people of all ages. We all need accessible transportation options to support our well-being and our continued engagement in civic and economic life. But we're really prioritizing at CalSTA accessible transportation, and I'm pleased to tell you how Governor Newsom's state budget proposal, which was just released a month ago on January 10th, brings some investments in these areas. So the governor's budget lays out a bold plan to bolster the state's strong economic growth and to make historic investments in California's future. Right now in California, we have a $45 billion surplus, and accordingly, the governor's budget is built on this strong fiscal foundation, and it prioritizes a lot of one-time spending using this budget surplus over the ongoing funding programs, which are also funded, but there's a lot of new programs in here, which I'm excited to tell you about. So this funding really gives us a unique opportunity to make a down payment on the kinds of investments that will help ensure California's prosperous future in transportation and in other areas. In transportation specifically, the governor's budget proposes almost $15 billion to fund programs and projects. And the transportation budget acknowledges right up front that we know that transportation and climate change are extremely interconnected. Transportation is the state's largest source of greenhouse gas emissions, and the transportation sector contributes to unhealthy air quality, particularly in disadvantaged communities. So one of the goals to help reduce the impacts of climate change and reduce those greenhouse gas emissions is to move toward a multimodal zero emission transportation future that will result in climate and health benefits and create a foundation for the development of sustainable communities. But in addition to those climate benefits, which are so important, a multimodal transportation system will also better serve older Californians and people with disabilities. A portion of the funding in the governor's budget is allocated to support multimodal transportation. There is $2 billion proposed for statewide transit and rail projects, and $750 million for active transportation, reconnecting communities, and bicycle and pedestrian safety projects. So this funding, nearly $3 billion, would support age and disability-friendly transportation through improved community walkability and expanded transit service and education. I mentioned that many of the funding programs contained in the governor's budget are for one-time spending. I want to note that the active transportation program does already exist, but the governor's budget would boost available funding for active transportation projects by more than 4 times what is normally available in a given year. So through these investments and more, the governor's budget aligns with our goals to advance public health, safety, and equity while addressing the climate crisis. And we're excited to see the governor's budget proposal move forward as the legislature considers it over the next few months. And we look forward to the passage of the budget later this summer. I'm going to move on now to talk about some of our updates on progress that has been made on the transportation items in the Master Plan for Aging, or MPA, as we call it for short. So the MPA, the Master Plan for Aging, focuses on transportation that supports an aging population, mainly by moving beyond cars and by promoting ways to improve community walkability, safer transportation, free bus and transit access, flexible transportation options, and older driver safety education training. Last July, my agency, CalSTA, released our Climate Action Plan for Transportation Infrastructure, which prioritizes investments in transit, passenger rail, active transportation, complete streets, and micromobility to expand mobility options and help meet the state's ambitious climate goals. In alignment with the Climate Action Plan for Transportation Infrastructure and the Master Plan for Aging, Caltrans, the Department of Transportation, released a new complete streets policy that states that projects should prioritize underserved communities that have historically been harmed or segmented by the transportation network. This complete streets policy specifies that projects should serve people of all ages and abilities and be inclusive of the mobility needs of children, older adults, and people with disabilities by embodying best practices related to speed reduction, universal design, increased user safety and comfort, and accessibility for people with disabilities. Caltrans is also actively working to develop and implement an accessibility tool, which they will use to analyze the ease by which travelers can access destinations such as work, shopping, school, healthcare, and recreation. What we mean by accessibility in this context is the number and proximity of destinations, as well as the directness of the trip and the condition and comfort of walking, biking, and transit facilities. So as part of this accessibility tool, which will be used to analyze projects, Caltrans is also exploring integrating demographics into the analysis, which could include age, disability, race and ethnicity, education level, and median household income, to name a few. We're also making investments to support free and reduced transit access for older adults. We have a new program that was just launched in December that's called the California Integrated Travel Project, or CalITP. We've launched now in the Monterey Salinas Transit District, which is the first agency to offer what's called CalITP's Benefits Tool. And CalITP's Benefits Tool allows any adult age 65 or older with a California DMV-issued identification card to have their eligibility for a fare discount on transit be instantly verified and instantly linked to their contactless credit card or debit card. Monterey Salinas Transit is the first public transportation agency in the United States to enable its riders to verify their eligibility for discounted fares online and to instantly add that discount benefit to a contactless debit or credit card. We are working on rolling out this feature with other transit agencies across California this year, and we're excited that that program will be expanded. Also, to support safer transportation, In 2021, we updated the California Strategic Highway Safety Plan, and that provides a comprehensive framework for reducing roadway fatalities and serious injuries on California public roads. And I just want to mention that that plan includes specific priority areas on aging drivers, pedestrians, and bicyclists. In addition, to support older driver safety education training, the Department of Motor Vehicles operates a senior ombudsman program, and that provides older driver safety education as well as alternative transportation and mobility options to California aging drivers. This program, it offers safety information and resources not only for drivers, but also for families, caregivers, friends, interested medical personnel, and other stakeholders who might be interested in this information. So that's just a really quick summary of the actions we're taking to make transportation safer and better for older adults and people with disabilities in California, and the funding that can make even greater investments in these areas through the governor's budget proposal. Thank you so much for your attention. I look forward to the transportation stakeholder presentation and the discussion that'll follow.
Thank you so much for joining us. We're so glad that you're here and that you're able to stay to hear from our stakeholders. So I believe now I will turn it over to DACLAC member Debbie Toth, who will lead the next section. Thank you, Debbie.
Ooh, I don't know that I'm a DACLAC member, and I don't know that I'm leading it, but I can be all of the above. If Susan says that's who I am, that's who I am. So hi, everybody. I got promoted today. My name is Debbie Toth. And actually, I'm going to introduce you to John Cunningham, who is a senior, I don't know, transportation planner. There's a principal in there, his title somewhere in Contra Costa County, who has been working in accessible and inaccessible transportation for over 20 years. And he's going to kick us off with some structure and history and some sort of grounding us in what is transportation for seniors and people with disabilities, older adults, elders, the full spectrum. And then you'll hear a little bit from some writers and utilizers of transportation. I'll talk a little bit, and then we're going to hear from Russell Rawlings about equity in transportation. So John, without further ado, take it away.
Yeah, thank you. Good afternoon, folks. Can everybody hear me okay? Great. Yeah, my name is John Cunningham. As Debbie mentioned, I'm a transportation planner in Contra Costa County. And my co-presenting colleagues will introduce themselves here in a bit. You heard from Debbie. Russell Rawlings is going to jump in, as she mentioned. They are the main event. I am the bureaucrat providing the landscape, frankly. So on that note, next slide. We want to start with some definitions. So we're all working from the same playbook. So when we say accessible transportation, we're talking about a broad range of services that you see there in the bullet points. We're talking about paratransit, dial-a-ride, mobility management. It's an inclusive term. And then the next piece you see on there is our thesis, which is, it's not controversial or even contested, and that is that the state of accessible transportation is it's not good. It's inadequate, it's poor, and it's stagnant. I'm going to touch on the stagnant piece here in a bit, as will Russell. Next slide, please. And so we don't want you to take it on faith that the state of accessible transportation is poor. We have a strong basis for that. The report from the master plan stakeholders referenced, I think, over a dozen or so reports. And this is just a sample, what you see in front of you. We have a quote from a national study by the transportation arm of the National Academy of Sciences. Folks can read the quote. I'll just point out specifically that this type of service results in duplicative, overlapping, and uncoordinated services. That's the highlight that I want you to take away from that study. And then the second quote you see there is from the Metropolitan Transportation Commission, which is in the Bay Area, but this finding is repeated throughout the state in similar studies. Again, the quote paints a dire picture. I would like you to take away from this, sort of the last point there is that senior-oriented mobility services, we have a lack of fiscal and organizational readiness. We'll touch on that here in a bit as well. Next slide, please. And then the master plan for aging, this group knows the situation for the master plan. I wanted to put this quote up because it indicated that this was supposed to serve as a blueprint for the state to move forward. And I'll address how the findings are not a blueprint and the problem with that. So we can go to the next slide, please. So this slide speaks to the aging demographics. We missed the title on this slide, but of all the slides, I think this group probably knows the situation best. So I hope you'll forgive that oversight. The quotes that you can see there speak to the aging of the population. The first two data points are pretty common knowledge. I'd like to point out the last quote that makes it clear that the aging dynamic, the aging demographics is going to very quickly morph into a combined aging and race issue. Next slide, please. So when I mentioned that I was going to provide the landscape earlier, this is really the heart of it. This is a list of actions that the state has tried to take to improve accessible transportation, with one exception that I'll mention, and that every turn there has been failure. And so we start sort of ancient history, I guess. In 1979, the Social Service Transportation Improvement Act was passed, creating the CTSA model, Consolidated Transportation Services Agency. There was no dedicated funding for this model or this mechanism. As a result, there wasn't much deployment of the tool, and there's very limited effectiveness, actually reducing over time. So then going through some other efforts in 2004, there was a master plan on aging. There were transportation recommendations that were never implemented. 2005, Transportation Task Team was formed by the state. They had transportation recommendations, none were implemented. 2007, we'll repeat that. They made many recommendations. There was no implementation. And then fast forward 10 years to 2017. And this was not an accessible transportation initiative, but it was sweeping legislation that reworked the transportation funding landscape, and included funding for just about everything under the transportation sun, except accessible transportation. You had road repair and maintenance, bicycle pedestrian projects, conventional transit, boating programs, park programs, university research, but nothing specifically for accessible transportation. The omission seems to scream for a cleanup bill, but that is somebody else's task to undertake. And then we get current with, of course, the 2021 master plan, where the Stakeholder Advisory Committee transportation recommendations were deleted and replaced with language from the state without consultation or even notification of the stakeholders. And so Russell Rawlings is going to talk about this situation in a bit. So I'll just say that from a planning perspective, the recommendations were based on widely accepted best practices recommended in countless studies and plentiful research. And as an understatement, what was included in the master plan, it was not a blueprint. It was described in the executive order. It did not address the lack of fiscal and organizational readiness. It was not a systemic solution for what is a systemic problem. And so as a result, accessible transportation remains stagnant after yet another effort. And the quote you see on the slide there, it is from the 2040 California Transportation Plan. It sort of unknowingly describes what is happening right now to this vulnerable population. The accessible transportation is negatively impacting their health because we just can't seem to get on top of our problem. And then the next slide is Debbie Toth's.
Thank you, John, for painting the bureaucratic picture of the reality of people who are living every day unable to get to and from where they need to go. So I think we have some videos to play right now, and then I'll talk at you some more a little bit afterwards. These are writers sharing their experience. Oh, I don't hear sound.
County. I've been writing for almost 10 years now. Unfortunately, I've always had issues with Link. They are constantly late, never on time due to a shortage of drivers and overbookings. I have gone to multiple board meetings to make changes, but I have yet to see any. If I have an important appointment, I always take other means of transportation to ensure that I arrive on time. I hope to see changes as I rely heavily on these services to get around in my community.
Sometimes my ride would take 3 hours. When I would be picked up from the bus station, and I get a notification from the link app telling me that the driver is going to be there in 10 minutes, and sometimes they're not. One time I got a notification that the driver is going to be there in 10 minutes, and I got at 4 o'clock, and I got picked up at 5:30. And it was dark, it was cold.
Hello, my name is Roberto Omar and I'm a resident of Martinez. I have mobility challenges that require me to walk with a cane. I rely primarily on public transit. Because of limited bus availability, it's difficult for me to get to work, to church, to doctor's appointments, and the grocery store. I am advocating for more funding for buses and bus stop benches. Thank you.
Hi, my name is Michelle Rousey. I use a power wheelchair, which makes getting places easier if it is close to my home, but not if there are sidewalks there aren't any sidewalks, or if the sidewalks are blocked. I'm an educated, engaged consumer who sit on Backlash, Track, East-Based Paratransit Rider Review Committee, and PATCO, Paratransit Plan Review, dealing with Measure B and BB funding in Alameda County. I also sat on the former California Olmsted Committee and multiple others. I have used fixed route and paratransit systems all over California for over 35 years. Having had that experience, I know I have the right to get where I need to go, but only if I live within 3/4 a mile of a fixed route stop. I have experienced delays in getting to appointments, long rides, no ride when too early, no same-day rides, and many other transportation-related issues. I know DACLAT can build a better accessibility transportation work group that truly moves things forward for those of us who do not drive. It is time to make transportation for all a priority. DACLAT's transportation work group must ensure we build a transportation system that works for all, because nobody else will. So thank you.
Thank you, Michelle. Nobody else will. You're exactly right. I'm going to read from a few more stories so that everybody has a rounded perspective of different barriers to accessible transportation. I'm going to then talk about the slide some, and then I'm going to punt it off to Russell. So thank you, Michelle, for sharing your story. The first is sadly not a rare occurrence. Having worked in long-term supports and services for more than half my life, I have seen this all too much. This story I witnessed. A 92-year-old monolingual Russian speaker with late-stage dementia had a paratransit ride scheduled to her adult day healthcare program at 9:30 a.m. with her return trip scheduled for 12:30. So we do these in advance. We schedule them in advance. Staff confirm with the transit company, and the manifest is approved and it goes with the driver. When the bus arrived to our adult day healthcare program that day and our participant was not on the bus, staff asked the driver where she was. And the driver said that she had dropped her off at a 102-acre public park alone. I remind you, this is a monolingual Russian-speaking woman with late-stage Alzheimer's disease. When asked the driver why was she dropped off there when this was her destination on the manifest, the driver said she seemed like she wanted to go to that park. The police were called and dispatched, and our adult day healthcare center staff who are Russian speaking went to the park to find her. And again, sadly, this is one of hundreds of stories of mishaps with frail elders with dementia, and it's painful. Our second story comes from a gentleman who is blind and has hearing loss. It's a brief story about navigating transportation in a rural area of our state with Nevada County Transit, and I'm quoting him now. I attempted to use public transportation in 2019, but I was frustrated by a driver's lack of disability sensitivity training with regard to my guide dog, and I ended up just walking from my house to Freed, which is about 5 miles. With regards to paratransit, I live 1.5 miles from downtown Nevada City. Paratransit only travels 3/4 of a mile off the fixed route bus system, which is a challenge for many of our rural older adults and people with disabilities, because many folks live much further away from the fixed bus route system than I do. The issue is that it's expensive to live in or near Grass Valley or Nevada City. So many people that I know want to live there. They have to purchase or rent a home far away from town so that it's affordable, which makes them out of range of public transit. As you are aware, most things are becoming less and less affordable these days for most people. That's the end of his quote. We went back and forth with some additional emails, and this ending of his final email broke my heart. It said, "But I often get exhausted having to explain that I'm allowed to move freely through this world." Just want to let that settle with everybody, because that's what lack of planning and investment in accessible transportation feels like for somebody who can't get in a car and go. Nobody should ever have to feel that way, and yet our built environment and systems of life do not include disability and aging in their design. On January 13th, our governor, Gavin Newsom, stated, quote, "There is no state in America that comes close to our commitment of radically changing our system of transportation," end quote. That's true, as long as you aren't disabled or elderly. Our system planning completely carves out these populations effectively by not including them in anything. The list of failures to implement that John Cunningham walked us through simply can't be dismissed as random. It's a pattern. It's a pattern so pervasive that we can only view it as being intentional. The solution? Super simple, right? The stakeholders laid it out in the Master Plan for Aging body of work, the over 800 recommendations that went to the cabinet level work group that were summarily discarded and replaced with some really benign sort of things like Band-Aids, not addressing the root cause of the issue. It's super, super simple. The recipe is right in front of you on that slide. Modernized policy and stable funding. It's that simple. So fund, expand, and empower consolidated transportation services agencies. What are those? Think about, like, we know in aging and disability, we know the aging disability resource connection, right? Think about that, but for transportation. It's a very similar concept. What are the needs locally? Where are the gaps locally? And how do we build a system around the needs of the rider? Very much like Marty's commentary about CalAIM. Ultimately, what is the impact for the person who needs that? CTSAs advocate for, organize, and provide accessible transportation services such as, but not limited to, walkability, rollability, affordability, volunteer driver programs, door-through-door services, same-day demand response rides, cross-county trips. I would be remiss if I didn't address the fact that what we're hearing about investments in transportation are surface. If we do not get to the core of the problem, the root of the problem, the policy, and we do not get to a place of ongoing funding, we will not see this problem eradicated, and people with disabilities and our elders will continue to navigate through this world having to explain that they have a right to do so. Russell, would you like to take it from here?
Thanks, Debbie. Good afternoon, everyone. My name is Russell Rawlings. I am the statewide community organizer at California Foundation for Independent Living Centers and facilitator of the Disability Organizing Network, or DO Network. I see so many friendly faces out here, and I am so glad to be talking to you today. Just so everyone knows too, I also identify as a person with cerebral palsy. I use a power wheelchair for my mobility. And so I'm going to shift gears a little bit and say that this is really a discussion about equity. And as you can see in this slide here, this is my favorite. Like, I've seen the equity discussion discussed so many different ways with graphics, but this may be my new favorite. And it's from Caltrans. So I think it's very fitting. And in that first, image there with the equality image, I see like massive disparity, right? That person in that wheelchair is being given a bike. And chances are that person can't benefit from that bicycle. And certainly the person next to that woman is also not really benefiting from a bike because they are having to put themselves in an extremely painful, hunched over position to operate it. And then finally, the woman kind of in the middle appears to be using the bicycle okay, but certainly the child in the front is also painfully struggling to operate the bike. Whereas in the second slide, we're seeing that there is an effort, a concrete effort made to provide appropriate bicycles for all involved. And so as you've heard from John and Debbie, there are so many issues that this system that was not built with equity are now pushing out upon us that we absolutely must get in and fix what is wrong, and that's the equity. And so, I think what we've got now, just to kind of summarize and really dig into this, we've got, the promise of a nothing without us about us approach from the aging community, the master plan for aging, and many of, all of us in this room probably are familiar with this phrase, right? It's one of the tenets of our disability rights movement. And in transportation, though, it's more of a, you get what we give you and you'll like it type approach. And that's real. You've heard from voices that are experiencing this. And really, honestly, it comes down to the very fundamental levels of all of this. Transit planning and even urban planning at large are not accessible institutions. It's completely ridiculous that I and other people with disabilities must become masters or even doctorate level experts on multiple subject areas, including public policy, transportation planning, and urban development, just to understand these systems, only to find out that they are failing everyone, including those that have the fancy titles and have learned all of this. I think most people would be absolutely shocked to learn that many people with disabilities who are living in poverty on SSI, in many cases, are attending Council of Government meetings regularly. Now, this is a very unusual public meeting that most people, I'd say maybe just a fraction of people even know exist in their community. However, people with disabilities are forced into these spaces for advocacy just to be heard. And when I first started attending my local Council of Government meetings, I was not the only one. There had been people with disabilities attending for many, many years prior. And so it's so important that we talk about equity. In order to even get this conversation going, the myriad of systems that even make up a transportation conversation, Caltrans, the California State Transportation Agency, and the California Transportation Commission, and our Council of Governments, and our transit providers, and so many more, they've got to all get on the same page. It's fitting that there has recently been an effort to establish February 4th as Transit Equity Day. It feels kind of strange to also know that this is the date of my birth. I could go on so long about the ways that access to transportation has changed my life, and it even encouraged me to move halfway across the country on my own with no family support. But I think that Claudette Colvin, one of the first to talk about transit equity, makes my point far better than I could. And she says, back then, as a teenager, I kept thinking, why don't the adults around here just say something? Say it so that we know, say it so they know we don't accept segregation. I knew then and I know now that when it comes to justice, there's no easy way to get it. You can't sugarcoat it. You have to take a stand and say, this is not right. And I'm certain that if you ask the majority of people with disabilities, both seen and unseen, who fall through the cracks, even as Claudette did, they would tell you this is not right. And I hope that you're all here to help us change that.
And I think Eric was going to share with us, our co-chair, his experience too, and open it up for discussion. Thank you, Russell.
Absolutely. Thank you so much, Debbie. Thank you, Russell. It's really kind of, it has my skin crawl right now talking about transportation. For those of you who might not know, I was born with my disability, physical disability. I'm a wheelchair user. I've been a wheelchair user for most of my life. And just in the spirit of what is was formerly known as the Olmsted Committee, of course, independent living, being able to live among the community with people without disabilities and those with disabilities. Transportation is a huge piece in being able to do that successfully. Throughout my life, especially as a young person, I wanted to be able to reliably depend on public transportation and paratransit, every form of publicly funded transportation that I could use. And frankly, I got to a point very quickly that I am sure many of you have, where I couldn't put up with it anymore. And I couldn't deal with it. And I had to figure out other forms of transportation. And I was in a fortunate situation where I could do that. But I know many in our community are not able to do that. Many people with different disabilities, many people who are aging are not able to go about finding other forms of transportation. They have to depend on public transportation and paratransit. So I really appreciate this conversation. And it's crucial, we've mentioned it before, but our budget, our state's budget, any budget, really lays out the priorities that we have as a community, as a state, for the people in the community and in the state. And this is a wonderful opportunity. We've talked about it pretty consistently in this conversation, in this meeting and in meetings prior, that we're in a major surplus as a state, and the state has an incredible opportunity to show the state, to show the people what our priorities are as a state. And so accessible transportation for people with disabilities, for people who are aging, is a way and should be one of the top priorities for the state. So I'm really looking forward to this conversation. I know it's a little after 4:30, but we hope to have a conversation with all of you and get your thoughts. And then we'll go into public comment after that. But does anybody have any comments that they'd like to make? I see a couple of hands starting to go up. So I'll go ahead and start calling on people. I see Jeannie Parker. I'm sorry if I Parker Martin. I'm sorry if I said your name wrong.
That's okay. Thank you. And thank you, all of you, for that excellent presentation. During the Master Plan for Aging discussions, we talked about transportation, and I know there are a few comments in the chat that we can't sit back. But we also talked about housing being a right, and transportation should also be a right. And I think that we have to really impact now, because the aging population and people with disabilities are going to continue to grow. So I don't know how we move forward in DACLAC. I think that's a question that I have. What do we do about this? And now are we writing budget asks so that transportation is placed in the right places and accessible to the right people, similar to what's happening with workforce, where there are transportation stipends, there are accessibility conversations, et cetera. So thank you again, and I'll look forward to seeing how we move forward to have action and not be passive any longer.
Thank you so much. So I'll go ahead and call on Peter Mendoza.
Thank you, Eric, and I really appreciate this conversation, and I want to commend everyone that's working on improving transportation in this state. Just a couple of observations. I'm a person with a disability, and I have cerebral palsy. And these days, I have transportation alternatives, much like Eric discussed. But I do remember not so long ago when I moved to Elk Grove, I told a bus driver where I needed to get off the bus after coming from the Capitol. And I didn't know my way around. And I didn't realize that the street intersection I was going to had a couple of different names. And the bus driver dropped me off 5 miles away from home down a very dirt road. And I was really stranded. Now, I had privilege. I was able to get a hold of someone to have a van that picked me up and get home. This ended well. But many times in my life, the same scenario did not. One of the issues that we have with transportation is a lack of coordination, especially for accessible transportation and no emergency backup service. Whether your wheelchair breaks down or you're not able to get to a bus stop because of something that happens mid-trip or because of an emergency, there needs to be processes for emergency backup services. Also, it's important to know that many people who are low income, those folks that go to meetings to advocate for accessibility and coordination for transit, are often very low income themselves. They rely on SSI or other benefit program, or they're working and they have high medical costs. They pay out of pocket. This is a barrier for folks to participate. Also, we are considered sort of a subset population by many transit decision makers, in my opinion. There are some times when districts listen to people without disabilities more than they listen to people with disabilities, or take us into account when they're planning. In closing, I just wanted to throw out the need for better coordinated transportation during a disaster or other emergency. We need to have systems where we can evacuate folks safely. You know, people with disabilities, as we all know, and older adults really are subject to extreme risk during an emergency, up to and including serious injury and death. We need to develop a system where people with disabilities and older adults and others with access and functional needs are given the option to evacuate early if they wish, so they can be safe in an emergency. And transportation to shelters and other supports need to be better coordinated, both getting to the shelter and getting back home. Thank you.
Thank you so much, Peter. We really appreciate your comments. Next, we have Janie Whiteford.
Thank you. Even those of us who are lucky enough to be able to not use paratransit, but have our own transit options, run into this issue too. And I think Peter was right on when he said, those of us with disabilities, as far as transportation are concerned, are like second-class citizens. And I often wonder why we have not used litigation and the Olmstead Act to push back on a lot of these issues. And I'm just throwing that out there. Debbie, you might have an answer, but why have we not utilized Olmstead in the legal system to be able to push back?
Thank you, Jenny. And I'm sure folks will probably have some comments in the chat and give a response to your question. Next, I'll go ahead and call on Gabriel Rogan.
Hi, thank you. Gabriel Rogan, North Bay Regional Center. Peter said a lot of what I was going to say, so I won't repeat it, but I completely agree. This is a question of equity and has to be a priority. As Marty said, it's really foundational. When we hold community meetings with the people we serve, this is often the #1 issue that is brought up. And I don't have good answers about why we haven't done more to address this. The other thing I would add is California is an employment first state for people with disabilities, and this is a major barrier to employment. That's just another piece of this. Thank you.
Absolutely. Thank you so much, Gabriel. It's so true that transportation is a key piece in our healthcare, in our employment, in our education. So it's so crucial that we have reliable transportation. Thank you so much. Next, I'll call on Robert.
Okay, so I live in a campus, now transit, and government have almost a say of what we definitely need to do transportation, and we can definitely get governance meetings across the state and not only in rural areas like mine. To hear our disabled voices of why we need better transportation. That's relevant, but if the transit agencies like mine or anywhere in the county itself like mine was late, that then we will not have a say on how we're going to do for better transportation. So thank you for bringing the issue up with governance meeting, and hope that our disabled community and our concern can definitely have a voice of what we can do to get better public transportation. Continue to bring the issue up to our committee. We really need it.
Thank you so much, Robert. Next, I see Vance. Your hand is up.
Yeah, hey, thanks, Eric. So I was going to touch on 2 issues. The first one was already addressed, which is employment. Such an integral part of being able to get a job, keep a job, promote a job. If you can't get there and you can't get there on time, if you can't get to work meetings, you just put yourself at a disadvantage, and really it becomes impossible sometimes to advance in your career. So that's one piece. The other thing I wanted to touch on is with my emergency management hat on. That anytime you've got a fire, it's almost like a law of nature that fire is going to happen in the middle of the night. It's going to happen on weekends, after hours. It's going to happen on holidays. And if you're somebody that relies on transportation, especially accessible transportation, your options of who you call and when are they open, and do I have to provide 24 or 48 hours notice in advance, become really critical really quick. So to be able to look at this question about I'm going to live independent in the community has to entail, as a part of that conversation, can I live safely in my community? can I evacuate my community? So just some questions that I think we have to consider as we move forward in this process and go down that road.
Thank you so much, Vance. So those are all of the hands that that were raised.
Eric, my hand was raised.
Oh, go ahead, Jeff.
Sorry. Or at least I thought it was. Sorry about that. I'm Jeff Tom with the California Council of the Blind. This is a fantastic discussion we've had. I'll keep my comments brief. Only two things, one bad, one good. Bad news perspective, in the long term, one of the things that concerns me is that when the pandemic eases, the general populace is going to be less likely to go back to fixed route transit because they're not going to want to be in that type of an environment. And I have a concern that you know, fare box receipts will never amount to what they once did for a long time to come. On the good side, though, we have an unprecedented short-term opportunity with all the money in the state surplus and based on what we're going to be getting from the infrastructure and other monies from the feds. And if we don't take advantage of that opportunity, and I don't mean the little things that the governor has, you know, suggested so far, but I mean in some really important ways, if we don't take advantage of it now, we may never realize the potential for real advancements in equity for people who are seniors who have disabilities. Thank you very much.
Thank you so much, Jeff, for your comment. Next, we have Anna Acton.
Thank you very much. Is my sound okay?
Yes.
Okay. Yeah, everyone's covered it. I just want to thank everyone for elevating this conversation. It's been really, really meaningful, and to hear you discuss not only just community living, but you know, employment, emergency preparedness. These are all such critical issues that really become a barrier for people to be able to live, work, and play in the communities of their choice. So thank you so much for the conversation.
Thank you, Anna. Next, I see Richard Smith.
Yeah, hi, everyone. Good conversation. Huge problem. The point I'd like to make is that we cannot look at transportation inadequacies as a transportation issue. It's really a health and human services issue. We need to be deeply involved in that. We need to, I mean, Transit's had the opportunity to deal with this since 1979 through the CTSAs that were created. And all I see are travel training programs, you know, things that really don't answer the questions or meet the needs of people who really need solutions. And so I think we have to think out of the box, think about what transportation means, realize that it means people getting where they need to go when they need to go anytime, day or night, without any other issues being involved. That means we probably have to rethink how transportation works, period. Get off the wheels, get off the old way of doing things. Think of something new, a new way to do it. One of the suggestions I have is that we can use our populations. I mean, for years, there have been programs where friends and neighbors have helped friends and neighbors. Let's really formalize that. Let's really get that going. So you can, you know, one of the questions was, who do you call? Well, wouldn't it be nice to call your neighbor? Wouldn't it be nice to call, you know, somebody who lives across the street? And they say, oh yeah, I can get you there and I can take you right now. Wouldn't that be wonderful? Thank you.
Thank you, Richard. So I do not see any other hands raised. And I know the next portion of our agenda is on public comment which we, of course, in prior meetings would cover hot topics kind of currently happening. So I'm assuming, Mariah, do you have the next piece? Sounds good. So I'll hand it off to you. Oh, you're on mute.
Thanks, Eric. I appreciate that. And I will try to navigate us through the public comment section. We have about 10 minutes left. And Nancy, I'm wondering if you can just pull up the slides that have instructions for that component. So for those joining us via Zoom, please use the raise hand feature to join the queue to make a public comment. And if you are joining us by phone, press *9 and that will add you to the queue. I do want to just say that with 10 minutes left, and I see some hands going up from our attendees, I want us to really just focus on public comments. So just know that committee members may not be able to respond to questions, but it is on the public record. I know we have quite a few things that were shared in the Q&A, and I'll try to summarize those the best I can. But first, I want to give Bill the opportunity to share his comment. He's been patiently waiting with his hand up for quite some time. So, Bill, I've opened your line and you should be able to jump in.
Okay, thank you so much, Mariah. I'm Bill Pelter, and I wanted to share that as great as the Master Plan on Aging is, and we all celebrate that, it's clear at the local level that we need accessible transportation because it directly affects what we can achieve at the local level for our residents. Additionally, we all know how devastating COVID was to our communities, particularly the underserved communities. We know that Health and Human Services and counties are looking at more of a holistic model of services rather than the model that we've had, and that transportation is key to helping provide services, accessible services going forward. I would add, as was mentioned early in the presentation, we're at the very beginning of the demand curve based on the state's estimate that 1 in 4 Californians are going to be a senior by 2030. So whatever we do now, we need to set the stage going forward to continue to meet the growing community needs. Thank you for the opportunity.
Thank you, Bill. Always lovely to hear from you. Jeannie, your line has been opened.
Can you hear me?
Mm-hmm.
All right. Hello, everyone. I'm Jeannie Wardwaller. I'm the Deputy Director at Caltrans for Planning and Modal Programs. I oversee one of our divisions is the Public Transportation Division. And so I just wanted to introduce myself to the group. Really appreciate all the discussion about public transit and transportation challenges, and just want to, echo and support what all of the committee members have said and the other speakers about just how critical equity in transportation is. Caltrans is deeply committed and has, really lifted up equity and accessibility for all users, all ages and abilities in our strategic plan just in the last couple of years. I think, we have a renewed focus on the issues that you're all talking about here. And I, just want to offer, my support as a leader on the executive team at Caltrans to work with you and continue to engage in this conversation. We've, obviously, I'm sure you all are aware, there's a lot of new funding coming to the state from the federal government for infrastructure investment and state funds proposed as well. So there's really a unique opportunity that we have right now to transform our systems. And I think we're committed to that. So I just appreciate all of the challenges and issues that you've raised today, and want to express my support from where I sit at the State Department of Transportation. Thank you so much.
Thank you, Jeannie. And I just want to point out that members in the chat are inviting you to join the work group.
Fabulous. Thank you.
So thank you so much for tuning in and for listening. Let's go to Shella. Shella.
Yeah. Hi, good afternoon. How is everyone? Oh my gosh. My name is Shella Comindumong, and I am the mom of a now 30-year-old trans male who has Downs, and also who lives independently but with support in his own apartment using a Section 8 voucher. I'm also the executive director of Chance Housing, and we find rent subsidies in existing community-based housing for vulnerable people, including people of all ages who have cognitive, intellectual, developmental disabilities, older Californians, single-parent households, families who have kids with disabilities, homeless people, veterans, and people who have traumatic brain injuries. Been a housing advocate, I don't know, over 23 years now. I also sit on the Developmental Services Task Force and their work group that deals with housing.
Sorry.
No biggie.
I just want to thank the committee. This has been a tremendous meeting. It has been so educational. And I really value the importance of the work that you're doing. It's amazing. I think it's also important to thank the California Health and Human Service Agency for advancing the important priorities of looking at the whole person and the person-centered outcomes for people. Also, the Department of Healthcare Services for pushing forward the innovations of CalAIM. And I really believe this will be transformational for so many Californians. And lastly, as a subject matter expert, I look forward to working on the housing work group in the coming months. So thank you very much for an amazing meeting. I learned more than you can even know. Thank you, everybody. Bye-bye.
Thank you, Shella. Cindy, your line's been open.
Thank you very much. There's one thing that goes hand in hand with accessible public transportation is the condition of our sidewalks in our towns and cities. Our sidewalks have been neglected for decades, and if you cannot go down the sidewalk, you can't get to the bus. Thank you.
Thank you very much, Cindy. And seeing no more hands, I just want to kind of summarize what's been shared in the Q&A. I'm seeing lots of folks who are volunteering to join the work groups. I just want to kind of restate that we're going to pull down all of the chat, all of the Q&A, and make sure that we have a list to follow up with. The other thing that's kind of coming up in the Q&A is just a big thank you to our presenters and Bill, who's sharing a resource, and I will go ahead and post that so folks can access it in the Q&A. And with that, I just want to recognize, Debbie, that you have your hand up. So I don't know if you had any final thoughts on the transportation piece before we pass it off to Susan for closing comments.
Thank you, Maria. I did indeed. And it was Jeannie that sparked my thought. We were finite in the amount of time we had to speak. So what I would add, if I had another minute, which you are giving me, and thank you for that, is that we need to include accessible transportation in every single piece of funding that we do for transportation. If you're funding a road, you need to fund accessible transportation. If you're building a bridge, you need to fund accessible transportation. With everything we do, we need to have the lens of accessibility added to the conversation and the financial calculation. And thank you, everybody, for your engagement, and let's move some mountains.
Thank you, Debbie, and thanks for organizing such an amazing panel. I know that was, for me, very impactful to hear all of the stories. Thank you. And with that, let me pass it off to Susan for closing thoughts.
Okay, so thank you to everyone for the entire meeting, but especially for the closing session on transportation. And Debbie, I just personally want to thank you that you took the disappointment of the recommendations not being included in the master plan, and instead of retreating, it was fuel for the fire. And we saw the fire today, and there are others who are joining. So Russell in the chat said we need DACLAC to elevate the issue of transportation. Patty said this is not a presentation, this is a call to action. Richard talked about solutions. And I just want to thank you. I called you a DACLAC member. You are an honorary DACLAC member. You are you are a leader. And John, Eric, and others on this call, you know, I would invite you, more than an invitation, and urge you to stick together and bring back some very concrete recommendations. It may be what you just said, Debbie, formula or a percentage or a lens that it's applied across the board, or it might be 1, 2, or 3 very specific concrete solutions that we can share and circulate, knowing that there is new funding and that much of it is time limited. There is a sense of urgency, and I heard John's frustration of, you know, reports from prior years. So let's do our very, very best as a stakeholder community to come back with a few things that can be widely circulated and can be considered for this funding, you know, for the state surplus and for the funding from the Infrastructure Act and other channels. So thank you for sticking with it on this topic. This is not an easy topic, but it clearly benefits many, many people if we could get it right. So thank you. Thanks to everybody, to the housing group that's been working. It's clear that housing and transportation are our 2 work groups initially, and there may be others. So anything that we can do, Amanda Lawrence, Sarah Steenhausen, myself, to support members of this group and the experts who have been joining with us, and other state department leads to get the work done between meetings. We're here, we're committed to that. So thank you, everybody. Our next meeting will be May 11th. I cannot wait to hear further recommendations from the housing and transportation work groups at that meeting. And no final thoughts other than to thank each and every one of you, and especially Patty and Eric for leading us today. Bye, everybody.